Sorry to disturb. We are going to start the session. Kindly be seated. I would like to invite the chairpersons one by one. I would like to invite Dr. Nibha Mohan, Madam. Ma'am, please come on the dais. Ma'am is MBBS, MS, FICOG, CIMP, Consultant, Renu Maternity Center, Patna, Treasurer, Patna Ops and Gynae Society, Clinical Secretary, POGS, 2019-20, Vice President, Patna Menopause Society, Secretary, Patna Menopause Society, 2018-23, Clinical Secretary, Sofsai, Bihar and Jharkhand Chapter, Executive Council Member, IFS Chapter, Bihar, Member of Pphcon Motherhood Committee and Medical Disorders and Pregnancy Committee. She is E-Zone Coordinator of Pphcon Family Planning Welfare Program. Presented papers in state and national conferences. Trained in ultrasound and endoscopy at Pphcon Center. I welcome you, ma'am. Now I would like to invite Dr. Anjana Sana, Madam. Anjana Sana, Madam, please come on stage. Good morning, ma'am. Ma'am is Professor PMCH Patna, National Trainer of BMOC, CMOC, RTI, STI, IPAS, Member of Medical Education Unit, Executive Member of Executive Committee of PMS and ISOPAP, Chairman of Family Welfare Committee and Chairperson of Safe Motherhood Committee. I welcome you, ma'am, Dr. Anjana Sana, ma'am. Now I would like to invite Dr. Neeru Goyal, madam. Dr. Neeru Goyal, madam. I think so. She is in the judge in the free paper side. Okay. Okay. I would request the chairpersons to kindly introduce the speakers. Over to chairpersons.
A very good morning to all of you. So we are going to start the first session, and for this I invite Dr. Milind Shah to please come on the dais. And he was President ISOPAB in 2016-18, member of Maternal Fetal Medicine Committee of AOFOCG, President IMA, Chairman Safe Motherhood Subcommittee IMA, Maharashtra State, and there are so many things about you, sir, but it's very difficult for keeping time, so you can go with your presentation.
Yes. Thank you very much for these kind words. Good morning, friends. When it's opening batsman, it's an honor in the cricket, but sometimes in the conferences, it's really a challenge. But looking at the chairpersons and all those elite people very much here, I feel myself honored when I can see the chairman, secretary, both are very much here. So thank you very much, Meena and Amita, for coming up for the first talk. Otherwise, I know it's a mammoth task to organize conference. Really wonderful. And yes, all three chairpersons are so close to me since so many years. So I feel, yes, now we can have some discussion. Though we know that we are going to discuss a lot on PPH, we are going to discuss a lot on the past. Since yesterday we have done that, and today also we are going to do that. But the task given to me is basically about the post-operative critical care, which is very important. And that's why I always feel that coming to Patna, I never miss an opportunity. This was the golden moment in my life when I got installed as the president of ISOPAB in this holy city of Patna by none other than Ramnath Kovindji. And just 3 months after that, he became president of India. So everyone from the Patna used to tease me whether it was Midas touch. But you know, friends, it is because of the hard efforts by all Patna OBGYNs, and especially from whom I took over, Dr. Manjugita Mishra, have worked so well in this particular belt that I know that a lot of things are improved. Previously we used to say Bimaru states, but now I feel these are the most empowered state now because so many programs, so many projects. Now, when it came to the post-operative critical care, I remember this particular quote. The great struggle in medicine these days is not just with ignorance and uncertainty, it also with complexity. How much you have to make sure you have in your head and think about. There are 1,000 ways things can go wrong, and that you will definitely agree always happens in cases of PPH or in cases of PAS as well. And we have seen that recently during our COVID era also. When we change our dress, when we change our actually the service providing to the parturient women who were COVID positive, and we could deliver even those positive women without taking into consideration the age and other factors and our safety as well. Now, I will tell you the story of Madhuri. Madhuri had come, diagnosed case of PAS. We had prepared everything, the antenatally, whatever need to be done, everything was done. But when we opened, the picture was something like this. We tried to avoid this vascularity, we tried to do something, but we could not save her uterus, and we landed up doing the obstetric hysterectomy. Similar is the story of the Poonam. Poonam had come from the interior of Karnataka, similar picture, and then we again landed up doing the hysterectomy. But what I realized that hysterectomy was done, but patient sometimes go in irreversible shock and could not be revived, and that is a always sad story. So we need to have a multidisciplinary approach for that, and we always do that. We always keep such patients in the unit where we have all this personnel available. The senior obstetrician, pelvic surgeon, urosurgeon, neonatologist and anesthesiologist. Not audible? Okay. One need to keep in mind all those risk factors which are there involved in that particular case. We should have a good investigations antenatally during operation as well. We'll have to take sometimes help of the interventional radiologist, and there's always a risk, so we need to deliver such patients at tertiary level care center. Multidisciplinary approach, as I told, doesn't need much emphasis. The keeping blood and blood products are very, very important. Especially what I realize, quite few of us, I don't know, even in today's era, people always think about keeping the FFP ready, PCB ready, but they forget to keep ready cryoprep, because we know the fibrinogen is the main concern. We know about the consumptive coagulopathy, and that's why we need to follow that MTP protocol, massive transmission protocol, to avoid all those postnatal hiccups in that particular given case. And the removal of the placenta need to be addressed according to this situation. We cannot apply the rule of thumb in this particular case, because what is most important is once you remove the placenta, probably she will have torrential bleeding. Probably you may be able to do something for that, like what we did for the Madhuri and Poonam, removing the uterus. But the next exciting field will be the more diverse and complex challenges. These challenges include identifying all the points in the pathophysiology in the individual patient, integrating care providers from multiple disciplines, addressing social and psychological concerns in the sick patient. I said social because quite few of them are non-affording patients, and sometimes we save them, but we make them more poor as well. So we need to take into consideration our government setups where free services can be given. And as a result of this complexity, this ICU care must be guided by a thoughtful and organized approach. So what is needed is a good equipments and drugs available. Again, I know that probably this slide appears very simple, but very important, because suppose I visit any particular ICU setup, there may be a actually problem that something is not available or something is not functioning. That should not happen, and that's why whenever we came for the EMOC certification to Ranchi and many of the states, we emphasized on that. I remember I had gone to the Ranchi Institute for that particular certification for the state training center for the EMOC. We said, keep all those things ready, and probably they may be of some use. For example, I'm having DPB in my own nursing home or the hospital, but you believe since 1990 we never use that. It doesn't mean that we should not keep it. We need to keep it because we really don't know. The day will come where we definitely need to use that DPB as well. It is very essential to see that the theatre staff, everything should be in place. There should be a nurse, we call it as a running nurse or the circulatory nurse, who should take care of all these arrangements, whether the bed is ready, whether the shifting is smooth, whether all orders are passed properly. All that is very, very important. You know, friends, this we emphasize more during the COVID era, when we delivered almost 25 Parturient women who were COVID positive, we applied a checklist, and that checklist became very useful for all this critical care as well, whereby our nurses also understood the importance of a running nurse who can give instructions and can coordinate with each other to see everything goes very smoothly. Now, these are the important aspects of the post-operative critical care. The monitoring, the pain management, hemodynamic support, antibiotic therapy, nutritional support, respiratory support, thromboprophylaxis if required, monitoring for complications, psychological support, and of course the rehabilitation and the follow-up. So suppose we address this, probably yes, you will be satisfied yourself, yes, whatever best need to be done for that particular patient, I have done that, and then you definitely have a very tight sleep in spite of having the patient in ICU after this very critical event. One need to see that this specific care required will depend on the individual patient's condition and the extent of surgical intervention as well. As I told you, that critical specialists are of great help, and the good nurses who can look after this particular situation is very, very important, which gives little more comprehensive concern for this particular patients. Now, let us quickly go through this. The continuous monitoring the vital signs, fluid balance, and the urine output to detect any signs of complications early is very, very important. Because stitch in time saves 9. That's very true. Suppose you identify something is going wrong, immediately you can take the rescue things implemented in that particular situation, and definitely we can avoid so many other complications as well. The pain control is very, very important. Why I am saying so? Because quite often, whenever we find tachycardia, whenever we find there is some respiratory distress, there may be a pain which is behind that, though patient sometimes is drowsy, but we never take into consideration. So it's very important to see that she get adequate pain relief, and the mobilization whenever possible, as early as possible, is very, very important. The hemodynamic support, again, doesn't need much emphasis, but very important. Quite often people get confused with the crystalloids and colloids, and they feel that suppose I give this, that will be better, and suppose I give that, that will be better, especially blood transfusions. They forget that sometimes we need to give the calcium gluconate after 4 points of any particular transfusion, because quite often in those days I know that the anticoagulant were giving rise to the calcium toxicity as well, and all those vasopressor medications to maintain adequate blood pressure. And syringe pump gives a wonderful result out of it. So that is very, very important. The good antibiotic umbrella, again very essential, because quite often when we do hurriedly all these surgeries, there is every possibility that there may be certain injuries to the other organs, or there is every possibility of infection as well, because of the so much hush-hush of that massive hemorrhage. So these are the remaining minutes, 2 minutes. So accordingly I will wind up. What is that? Yeah, it's remaining. Okay. So I will go a little fast as well. Great, yeah. The respiratory support, yes. In some patients, patient may require mechanical ventilation to support their breathing. Now, quite often I have seen that suppose, the critical care intensivist says that I need to put the patient on ventilator. As OB/GYN, always used to feel, patient is breathing, little tachypnea, rehne do. But no, we'll have to give that decision to the respiratory consultant. Probably he may use BiPAP or the ventilator, and we'll have to cooperate with him whatever is required. We forget the nutrition, especially I have seen diabetic patients as well. We think about insulin, we may think about the giving proper glucose support, but we forget to address her proper nutrition as well. Otherwise, there's every probability that she will go into ketoacidosis, because the fat will get utilized more, and then there is another complications which will come in front of you. So giving insulin, at the same time giving nutrition, need to be balanced with the help of your diabetologist. One need to see that to prevent blood clots, we can think about compression stockings, or sometimes the blood thinning medications, because we know this hypercoagulability of the blood during pregnancy, and we are here going to deal with a lot of endothelial injury. There is a possibility of more status because of the longer duration as well. So the method of prophylaxis, again, not necessarily immediately heparin. It is definitely have a lot of other aspects as well, the general measures, the mechanical. Now, of course, heparin and others are always there for our rescue as well. But we need to take into consideration about this use and misuse of heparin as well, which is very, very important. and the risk scoring need to be calculated. I always tell my actually the delegates or wherever I go and give this talk. For example, recently I went to Kolkata to deliver this oration, Dr. Raj Kishori's oration, again a person from your own holy city, and I delivered this talk on mis and misuse of heparin. I emphasized on this particular scoria. 2 minutes, I'm going to, yeah, okay. Thank you very much. So this score is very, very important to understand where we need to give the heparin or no. Monitoring of complications is very, very important because wound infection, UTI, thromboembolism sometimes are not addressed because patient is now stable. But eventually she may start getting fever from third day and we get again panicky. Sometimes the sepsis can go to, very critical situation as well. So one need to take care that this properly address. Yes, and lastly, this is again very important, the psychological support. You just understand, these are young patients. They have come to you for the hope of childbirth. And they met with this particular very Draculian complication. Just go into the, there actually the side and think about the patient, the family. So it's definitely essential to have a sympathy and empathy with these patients to understand that we are trying our level best, but at the same time we are speaking also. What I have done, I will tell you a very, very good example of it. I appointed Rohini in my clinic. Rohini is a certified counselor. She has done her diploma in counseling from Symbiosis Pune. So she takes care of speaking. Because we are so worried, we are worried whether patient will die, whether relatives will attack my hospital, whether relatives will go to the police. But the Rohini very calmly, because her job is only speaking, she does that and she's updated whatever happens because she's in the team. That makes a major difference, and probably all of you will have to think about it when we have so many youngsters, Youth Express available for this particular noble cause. The post-discharge, again very important aspect, rehabilitation, the follow-up need to be addressed very properly. We'll have to put all those notes very clearly, whatever you had done. A last story in that I'm going to wind up because there are a lot of slides remaining. But I remember once we did the same thing actually in one of the past case, and then the doctor from Karnataka, her aunt, the patient's aunt used to call that patient saying that, "Arey, आपका uterus तो निकाल ही दिया होगा." And I used to say, no, we could conserve the uterus. But she used to deny. And the patient and the relatives were so much after me कि नहीं डॉक्टर साहब आप शायद uterus निकाले हो. मेरी मौसी बोल रही है. I said, no, I have not removed the uterus. Finally, we needed to do the ultrasound to show that uterus is intact. So it is very essential that put on everything in the proper fashion as well. I'm going to skip all those slides because I understand that all that will be covered eventually as well. And the time is up. But only last two slides and then we can go further. So whenever we say about the procedures, we know about the hysterectomy in post-op care. But the conservative treatment also need to be addressed, and that starts with the antenatal period as well. It is essential to achieve the optimal timing of the delivery, where at 35 to 36 weeks when everything is prepared and then patient doesn't come in crisis or the bleeding at wee hours of the morning or late night, when it is difficult to manage that particular case. It is essential to see that whatever best can be done, we should do that. The conservative approach is also good, but that need to be addressed very, very properly in taking into consideration all those points of clinical examination, pelvic USG, laboratory, bleeding, temperature, pelvic pain, volume of the retained tissue, CBC, CRP in vaginal culture as well. And then whenever actually there is something goes wrong in conservative, we'll have to think about the TH as well, because it has been found that the 22% of this conservative required hysterectomy, and the hysterectomy is recommended by even many organizations like ACOG, because it found that definitely it gives better actual survival compared to the other things. The triple procedure is very important, and the stepwise devascularization also need to be understood. Whatever delay happens, as you can see in this last slide, can definitely cause some catastrophe. So we'll have to see that the delays need to be avoided. So friends, thank you very much, and thank you the chairpersons, organizers for the extra couple of minutes. I know that it is difficult to finish this care in given 12 minutes, but I'm happy that I could do that. And once again, thank you very much, friends, because as I told you, this moment I will never forget, and definitely it's going to cherish entire my life when I got installed here at the hands of Ramnathji Kovind, and many of you are a witness of that. Thank you very much. Thank you. Thanks a lot. Yeah.
Very elaborative talk, and three things which you pointed out are very important, like timely referral, and every equipment should be in condition when a patient is received in an ICU. That was very nice, and every now and then it should be seen that the instruments are working properly. So thank you, Dr. Shah.
Thank you, sir. And good morning, everyone. And thanks, organizers, for this opportunity for all of us. Our next speaker is Dr. Sita Ramamurthy Pal. She needs no introduction. We all know her so well. She's pride of Bengal and very active Pphcon and sweet and very, well-known gynecologist of Bengal and at the national level. To introduce her formally, she is consultant fetal medicine and obstetric Apollo multidisciplinary speciality hospital at fetal medicine, Kolkata. She is FICOG, FRCOG, and she has done advanced obstetric diploma in USG. She is at present treasurer of Bengal Obs and Gynae Society, chairperson of Genetic Fetal Medicine,
That's
Phoxy.
fine, thank you.
Yes,
Thank you.
and she is doing so well
Thank you, Niba.
as a chairperson and as a great Phoxian.
Thank you.
Welcome, Dr. Sita, and
Thank
she
you.
is going to talk about imaging in PAS.
Thank you. Thank you, Dr. and Chairpersons, and thank you, Dr. Meena, Dr. Amita Sinha, all the POCS team and the seniors here, Dr. P.K. Shah's here. It's an honor and privilege to be here. It's always like coming back home. So thank you once again for this opportunity. So today my topic is going to be imaging in placenta accreta spectrum. We all know that this is a dreaded complication that we all fear, but what is the key is to know it antenatally, and that is what we are going to talk about today. What is the evidence and how we can improve our detection of this dreaded condition. And this is me for you. Once again, thank you. So what is placenta accreta spectrum? As we describe it, it's different grades of the attachment of the placenta to the uterine wall. Now what happens is normally when there is a decidualization occurring, there's a failure of that normal decidualization in the area of a previous uterine scar. So it is important to know that there is a scar there, and when there is a niche, when the scar is not healed, that is where there is a failure of decidualization, and then the placenta gets adherent there. So what happens, we know the entire spectrum, it no longer is divided into accreta, increta, percreta. The whole thing is called the placenta accreta spectrum. And here the accreta is where only the placenta adheres to the myometrium. When it goes beyond that, that's percreta, that's increta, when it invades the myometrium. And when it's percreta, it actually invades the entire length, the muscle of the myometrium, entire thickness of the myometrium, going up to the serosa and even beyond. Now that is what happens, and here the important thing to note, why we fear is because in the increta and percreta, the villi penetrate the vascular architecture there, the radial and arcuate arteries, and that is why it is so vascular. And we have bleeding and sometimes death. So it's a very dangerous obstetric condition. We fear this because maternal mortality can occur, and the ferocity and the ferocious flow, bleeding that can occur is really scary. And survival actually depends on prior preparation. So how do you prepare yourself? You need to know what is happening, how you can map yourself, how you can be prepared during surgery. So the key is antenatal diagnosis. And why the problem is because even now we realize that up to 2/3 of the cases they become undiagnosed in emergency settings. There is lack of awareness in the population that this can be detected, and of course poor training in detecting this as well, and that is what we are here to be aware of. So the mainstay of diagnosis is ultrasound. It's still ultrasound. I'll show you studies which says that ultrasound is the key and MRI is just an adjunct. So ultrasound is the key. So what happens, the risk factors, we start off with anything as to how you predict, how you can assess these women, because it's not possible for us to screen everybody for them, so you have some risk factors. So the two most important risk factors, if you have to remember, is a lady who has had a previous cesarean delivery and an anterior low-lying placenta in the current pregnancy, whenever that is in the anatomy scan. but there are measures to see it earlier as well. So in the presence of placenta previa, again low-lying placenta, the risk of PAS increases. Sometimes you can see, yesterday we saw a video where he said there was a primea gravida, Dr. Gupta had shown that she had an, a placenta accreta sort of a spectrum. So it can happen there, but the risk is 3% in those without a previous. But with a previous, it increases to almost doubles to 10% with one, 40 and almost 60%. We don't see that, but 60% in ladies with 3 cesarean. This was a study done by the King George, the St. George's Hospital in London, and they said that when they found a placenta previa at 32 to 34 weeks, 1 in 5 of them had 1 or more previous cesareans. Overall risk in their study was 5%. So with 1 previous cesarean, the risk was 15, and 2 it increases to 37%. How do you predict them? The PAS actually often masquerades as a scar pregnancy in early scans. It is important to remember that only when you have a niche, that is the scar is not healed, then you can have the placenta implanting there or the sac implanting there. If the scar is well healed, that means that there should not be a problem. So it starts when you are operating on a first cesarean to make sure you close the endometrium, the layers properly. And if there is a niche, if there is a problem, you detect it in the interval period and see if you can correct it laparoscopically. But if that is not healed, that is a precursor for your cesarean scar ectopic. So typically you will have the cesarean scar in the pregnancy in the cesarean scar, and that is what you would call as a cesarean ectopic. So you would have typical signs in the early pregnancy, that is empty sac, empty upper part of the uterus. The sac is at the level of the internal os or scar. The myometrium above it is quite thin anteriorly, and there's an empty cervical canal. Now, studies have recommended that you should ideally be screening between 6 to 9 weeks to look at scar ectopics, because a lot of times we see that a patient has a medical termination, a DNE has been done, and then we see. But if you have to actually detect them, you see them at 6 to 9 weeks, because after 9 weeks, the head of the gestational sac starts moving towards the fundus, and you might not be able to see it typically. So again, you have, when you put flow here, you will see there's a high velocity flow. The peak systolic velocity is quite high, and the PI is also low. Now you have to differentiate this between a spontaneous pregnancy loss, which is typically when you put a transvaginal probe, there's a negative sliding sign. That is, the sac does not move when you inability to displace the gestational sac from its position at the level of the internal os when you apply pressure. So it is important to differentiate that this is not a failing cervical or a failing pregnancy rather than a scar pregnancy. So this was a reporting system. Again, we are all moving to the methods of Delphi methods, and they have said that you should put an uterine cavity line, a serosal line, and this is where the niche is. So the scar actually, the ectopic pregnancy, the pregnancy actually grows in the niche. If it is just touching the niche, it is reaching the niche, it is actually a low implanted pregnancy, it is not a scar pregnancy. So you can, diagrammatically see these and decide whether it is really a scar ectopic pregnancy. And then they have divided into scar ectopic into 3 types, as to one where the larger part of the sac covers the uterine cavity line, the larger part of the sac does not cover the uterine cavity line, and this one actually crosses the serosal line. So sometimes we see that the scar ectopics, they grow into the uterine cavity, they can end up in a normal pregnancy. So these are the predictive factors where the other 2, B and C, will progress to a scar ectopic, or if she progresses, it will be a placenta accreta spectrum. You can also detect this between 11 to 13 weeks, where they have studied and they have said that a placental implantation of an exposed lower uterine scar can be cardinal, and it has an excellent negative predictive value. So they have divided it to something called a cervicoisthmic canal, and if the scar is above the cervicoisthmic canal, this is the cervicoisthmic canal, if the scar is above and the placenta is lying above it, then it is high risk. You follow them up at 20 weeks, and then you can, if it is not, then it's a low risk. But mind you, you never say a placenta low lying at the 13 to 14 week scan, because the placenta, it's usually, the uterus is a pelvic organ. So when the anatomy scan, when you see a low lying placenta, that is when you label it as a low lying placenta. These are all predictors to follow them up. Actually, you don't label them as a low lying placenta. So here is, when you look in the 3rd trimester, you have to have a concept of what is normal. So there is a placenta here which attaches to the myometrium, and there has to be this hypoechoic line we all keep talking about, and that is normally seen in all normal placenta that is adhering, and that is where we look at for ultrasound. So what are the ultrasound criteria? We have grayscale criteria and a color flow criteria. So grayscale is the typically loss of clear zone, which is the loss or irregularity of the hypoechoic plane in the myometrium, which is about 70% of the past cases you can find. Then the next finding is typical lacunae. These are spaces, numerous lacunae in the placenta which contains turbulent flow, because as I said, these are invading the arteries. Then there is, if it goes ahead, there is a bladder wall interruption. You see a line, the thin line, myometrial line between the uterine serosa and the bladder is obliterated. There's myometrial thinning. It's sometimes very difficult to measure, but they have categorized this to less than 1 or 2 millimeter. And of course, it is protruding completely. You see a focal exophytic mass. When color flow, there is a placental lacunar flow. These lacunae are filled with blood, so when you put color, it just fills up. That is an important sign. You have subplacental vascularity. I'll come to the images, which is a striking amount of blood flow behind the placental bed. And there are uterine vascular, that is utrovesical hypervascularity, because they're sharing the blood flow, and these are called the bridging vessels, which comes between the uterine serosa and the bladder. So typically this would be a placenta that is, I hope the video works. Yeah. And this one is typically anterior. This is a transabdominal scan at around 37 weeks. She came unbooked, and we can see the lacunae, the color flow. So this, you can prepare the surgeon, talk to them that this is where it is. You be prepared, and you know what you can expect, and do whatever necessary has to be done. So I have 2 minutes, let me rush. So we have graded placental according to the grading, but it is just for clinical, it is just for grading for ultrasound, but clinically significant, it only matters when it is actually accreta and percreta. A systematic review showed that the loss of clear zone and the presence of bridging vessels were the most common ultrasound findings found in cases of placenta accreta. And then for increta, a loss of clear zone and subplacental vascularity, and lacunae and subplacental vascularity was seen in percreta. So this is again a lady at anatomy scan where she had previous 2 cesarean sections, and you can see the placenta, the bladder, the serosa is actually, the myometrium is the loss of hypoechoic clear zone, and there is vascularity. There's actually thinning of the myometrium, and you can see it's almost bulging into the bladder. This is again another case at 21 weeks. This was recently a case that was done. She was operated. She came in with PPRM, and she ended up in a hysterectomy. So these are signs where we can see, and we can warn the obstetrician. This was actually protruding into the bladder. So the bladder was, the lady was opened. It was a typical placenta accreta cases. So this was a transvaginal scan at 19 weeks. Again, you can see almost like an exophytic mass going into the bladder, and she had to terminate the pregnancy because she came in with bleeding in the 2nd trimester. So what are the technical issues? Ideally, we say a transvaginal scan should be done, but usually what we say, a transvaginal scan has to be run on an empty bladder. This is one of those situations where you have to do a transvaginal scan on a partially full bladder, because you see the bladder interface, you want to see that line where it is actually protruding into the bladder or not, measure the myometrium. So this is where you have to use a partially full bladder in a transvaginal scan. And secondly, your probe should be, you should, like you look for cervical assessment, you should not apply undue pressure. It should be a light pressure to see where is the interface and what is the distance. So again, probe pressure and color Doppler, obviously you will see all those signs. Next is ultrasonography criteria actually has a good detection. With color Doppler, the sensitivity increases to 90 and specificity is 97%. This was a study of antenatal detection of placenta accreta disorders, and they found that placenta accreta was considered to be clinically significant if the histological confirmation happens. So ideally, you should send these placenta for histology, and if these procedures were carried out, at least one of these procedures were carried out after delivery, that is intrauterine balloon, compressive sutures, or hysterectomy. So when you combine all this, you have to actually correlate with what you're finding and what you see after the delivery and what procedures were done. And what is the role of MRI? Though they said that there are different features like uterine bulging, interplacental glands, they can be considered if there is a posterior placenta, but it's debatable because there was this is how it looks in a placenta percreta. There was this study recently in 2022 when they said that ultrasound properly implemented with the application of criteria done by experienced hands can be superior to MRI, and it's absolutely sufficient for the diagnosis, especially because if you're planning your cases. So MRI is not actually mandatory for you to diagnose placenta accreta syndrome. I'm skipping these slides. Yeah. So basically, the key messages is that purposes of prenatal diagnosis to forewarn the obstetric team and the possibility of significant morbidity and mortality. Aim of imaging is mainly ultrasound-based, and it is used to detect the past disorders of clinical significance, such as increta and percreta. So preparedness is the key for anything, and imaging, especially ultrasound imaging, is the best investigation modality available. And use it properly, interpret it properly, and liaise with your ultrasound colleagues or whoever is doing it, so that we have a team approach and save the mother. Thank you so much for your patience here.
Thank you, Dr. Sita. Beautiful presentation about ultrasound finding. If it's diagnosed antenatally, it's really boon for the patient and the baby being to be born. I think.
If there's any doubt, call up who's done the ultrasound and speak to them.
And get it confirmed. Thank you so much. Now we are moving for the next talk.
Now, good. Now, I will like to call Dr. Sukant Mishra to the stage. He will be speaking on secondary PPH. He is the professor and head at Vivekanand Institute of Medical Sciences, Calcutta. He was the president of Bengal Obs and Gynae Society. He was the founder president of Bengal chapter of Society of Vaginal Surgeons of India. He is the president of Calcutta chapter of ISOPARP. He is the peer reviewer of Jogi. He is the member of PhD committee of.
Thank you.
Welcome, sir.
The slides. Somehow.
Secondary PPH.
Okay. As a matter of fact, it's my prerogative to offer sincere thanks to. Okay. Which one belongs to mine? Come. Which one belongs to mine?
He's doing it from there.
Okay.
You just welcome till the time. I'll fix it up.
I take this opportunity to offer. I'm not audible. You know, this topic is like that. It never gets any attention. It's only the primary PPA that gets the entire attention. Since yesterday, you all are aware that this is a problem which can create havoc. It's a devastating one, and it takes the front seat. And it is a secondary PPH. It never gets any attention whatsoever, and that is why it is neglected and always behind the curtain. But yes, before I start, I must thank Dr. Meena Samant, Dr. Amita Sinha, and the entire organizing team, and the members of the POGS for inviting me to participate in this wonderful conference. As I said, yes, secondary PPH is not without consequences. It can have a lot of consequences, like it might require hospital admissions, besides the effects of severe hemorrhage, which can occur sometimes. And unfortunately, hysterectomy may be required in certain situations. But this hospital admission and the effects of PPH and the complications of treatment can also adversely affect the maternal emotional well-being, the bonding with the newborns, and of course definitely breastfeeding, which has got so many advantages. Finally, despite every possible treatment, maternal death is not a rarity. There are case reports. So secondary PPH has some importance. Now the question is how to define this condition. Again, you will notice that yes, it starts after 24 hours, but how long? The traditional definition is up to 6 weeks, but the recent literature says it can continue up to 12 weeks. So that is the major difference. And second point is, in contrast to primary PPH, there is no volumetric definition of secondary PPH. That creates a problem because the secondary PPH more often than not becomes a subjective one, and naturally, the specific incidence of this particular problem remains unknown to us. However, some of the studies report that in high-income countries, approximately 2% of the postnatal women, they require admission for this particular reason. Now, what are the causes? Whenever a patient comes to us with secondary PPH, we all know the most important cause and probably the commonest cause is retained products of conception. And with or without subinvolution of uterus, with or without endometritis, maybe there is a fibroid as well. But besides that, traumatic causes are also a distinct possibility, which includes different types of trauma, vascular abnormality, which includes arteriovenous malformations, pseudoaneurysm, placental abnormality, which Dr. Sita has just now discussed, that if the management is medical and the placenta is retained, that can create, again, problem in the puerperal phase. Rarely choriocarcinoma and some of the coagulopathies can also manifest as secondary PPH. So we must take all those factors into account. Now, what are the possible risk factors? Can we predict this? It's difficult, but it may not be impossible. One has to be careful enough. But if there is a past history of secondary PPH, if the lady is multiparous, during the pregnancy, if there is history of PROM, threatened miscarriage, APH, multiple pregnancy, and hospital admission due to some reason or other during the third trimester. But the most important point that we should look into is the labor history. Caesarean delivery, precipitate labor, prolonged third stage, and incomplete removal of the placenta and or membranes. Often it is documented in the case sheet. If it is there, then of course it increases the chance of secondary PPH. Besides that, of course, if there is a history of primary PPH in that particular pregnancy and puerperal sepsis, that also can lead to secondary PPH. How does it present? 95% of the patient present within 2 weeks, within 4 weeks, and nearly 60% patient present within 2 weeks. So if you can manage 2 weeks without any bleeding, yes, you can say 2/3 of the possibility is reduced. And mostly, at the time of presentation, the bleeding is so variable that most of the patients, they are hemodynamically stable and may not require any admission. So how are you going to manage it? Yes, we need to assess the hemodynamic status of the patient. We need to assess the bleeding pattern of the patient, and we also need to evaluate the emotional aspect of the mother. The entire thing is just to provide basic resuscitation to the mother if she requires it, depending on the amount of bleeding, and to look for the cause of the bleeding, which is so diverse, and to tailor the treatment according to the cause. That's most important. Now, as I said, approximately 10% of the patients present with massive hemorrhage. Naturally, the resuscitation comes first, then one should look into the causes. But if the bleeding is less significant, then of course both the things should be continued simultaneously. But primarily, to look for the cause is very important because we need to tailor the treatment accordingly. Now, while evaluating, we need to depend on those tripod, history, examination, and investigation. In the history, as I said, the risk factors should be looked into, like particularly the factors that is important during pregnancy, whether she is multiparous, whether there is any history of delivery, details of labor process, any history of incomplete removal of placenta, and so on. All these things, and any relevant family and medical history which can contribute in the management of PPH. Then signs and symptoms, like if there is any history of pyrexia, offensive discharge, tender, enlarged uterus, subinvolution of the uterus, and all these things should be looked into. But always it's very important that normal postpartum loss of blood may continue even beyond 6 weeks in up to 25% of the women, especially if they breastfeed their children. And the first period may be heavy, prolonged, and painful. And this particular information needs to be shared with the lady. Investigations, yes, blood. What is the status of the hemoglobin? And CBC needs to be done. Coagulation screening, CRP, and serum HCG to rule out choriocarcinoma. Swabs should be taken both for aerobic and anaerobic culture from the appropriate sites to look for the evidence of infection. If the symptoms suggestive of urinary tract infection, urine should be sent accordingly. If the most important investigation, as Dr. Sita was suggesting, is her prerogative to look into the cause of bleeding. But unfortunately, the positive predictive value of ultrasonography in diagnosing the cause of secondary PPH is very low. That means we'll overdiagnose the condition and we'll overtreat the patient and naturally its consequences. But the positive thing is that negative predictive value high. That means that if there is no evidence of anything inside the uterus or any sonographically detected cause, then probably we can exclude that there is nothing wrong and we can exclude products of conception. Now, if the bleeding occurs within first 7 days, then the accumulation of blood clot can, how much time I have? Accumulation of blood clot can create little confusion, and in those situations, duplex color Doppler can be helpful because the written products of conception can sometimes have some blood connections. As of now, there is no international agreement as regards to what exactly should be the USG findings to diagnose this condition most accurately. However, some of the studies suggested that it is the echogenic mass and thickened endometrium are predictive. Some of the studies says besides echogenic mass, the anterior-posterior diameter of the uterine cavity is more than 25 millimeter between 1 to 7 days postpartum. However, whenever there is suspicion, we should look into this, but please don't forget the clinical findings. In the presence of evidence of massive bleeding and open cervical loss, before taking any surgical decision, one must look into the clinical criteria. Also, that's extremely important. So this is one slide where you can see that yes, we can identify this colored Doppler can identify this problem and can differentiate between the region products of conception and blood clot. And besides that, chest X and CT scan in cases of choriocarcinoma, MRI if there are suspicions of PAS, pelvic angiography to assess the different arteries, and angio-CT in certain situations, particularly if there is extraperitoneal pelvic hematoma, although it can be diagnosed by sonography as well. The management depends on medical, surgical, and radiological. Medical, we all know the uterotonics, antibiotics, tranexamic acid, depending on the amount of bleeding, and chemotherapy if it is a case of choriocarcinoma. Surgical is primarily evacuation of the uterus with or without the help of ultrasonography and hysteroscopy, and radiological is arterial embolization. So these are the agents that we commonly use. Antibiotic is the common antibiotic. Ideally, if we can identify the organism, it's best, but it's not possible always, so we go for ampicillin, gentamicin, that is adequate one. In absence of that, one might consider clindamycin and amikacin also. Other medical therapies, yes, if there is bleeding, you can go for tranexamic acid and other parameters. If there are coagulation disorders, you consult hematologist, and if it is a case of choriocarcinoma, one can consider chemotherapy. Now, while evacuating the uterus, it is extremely important that it's a procedure that can have complications in the form of uterine perforation and Asherman syndrome. So it is ideal that a senior person should go for it with utmost precautions not to create any problem. And second important factor is that this material must be sent for histopathological examination, not only to rule out RPOC, but also to rule out choriocarcinoma, which can be a dreaded complication. If the patient, however, following surgical evacuation doesn't respond appropriately, then there are certain other things that we need to consider when these situations can arise, like if bleeding is not controlled, when there is a large bleeding leading to pelvic hematoma, which can be diagnosed by ultrasonography. Also, non-union of the scar, bleeding from a surgical injury, and uncontrolled bleeding from previous lower genital tract lesions. And the procedures that can be utilized are uterine balloon tamponade, surgically laparotomy, all the compression sutures, artery ligation, hysterectomy, whatever is required just to save the life of the patient. And latest in the armamentarium is the transcatheter arterial embolization of the appropriate vessels after diagnosing the conditions with pelvic arteriography. As you can see over here, there is evidence of extravasations, there is a definite vessels injured, and yes, we need to tackle it with the help of our radiologist friend. But when you look at for the evidence for the treatment of secondary PPH, in a Cochrane review in 2008, they have identified nearly 100 randomized and quasi-randomized trials, but none of the trials were adequate enough. And Cochrane concluded that no evidence of any treatment from RCTs of secondary PPH. Even the RCOG failed to provide any adequate treatment. So We looked into the evidence and we found that the systematic review was published last year only, just a couple of months back. And in this particular review, they have taken patients very rigorously. The abnormal bleeding between 24 hours and 12 weeks were considered when they bled after 20 weeks of pregnancy. All interventions were taken into consideration. And there are comparator groups as well, and single intervention studies were also included. 100 studies were selected, 11 of which met the inclusion criteria and included in the review. Now, the total number of patients are nearly 1,000, and it was found that the medical management varies to the extent of 8% to 84%. Surgical management is the most appropriate, and latest, as I said, is the interventional radiologist's job to embolize the appropriate vessels. But this systematic review published last year has certain limitations. Limitations in the study design. There is a high risk of bias. The reported outcomes were heterogeneous and variable. No studies are reported from low middle income countries, which is very important, and all the studies were retrospective in nature. There is no prospective studies. So there is a plan to design a study which should take account of rigidly the standardized definition of secondary PPH with inclusion and exclusion criteria, like the patient needs to be stratified according to the severity of blood loss, and the treatments needs to be offered. All interventions, including evacuation under USG or hysteroscopy, should be taken into account, including the latest ones. And the outcomes should be well defined prior to the study to assess the efficacy of treatment, to assess the morbidity and complications associated with the treatment and other outcomes, particularly the social outcomes, economic burden, patient's level of satisfaction and effects on breastfeeding.
We added 2 minutes. Yeah. We added 2 minutes to you, please.
Okay, thank you very much. You are very generous. Currently, as of now, what we could feel that there is minimal evidence to guide the clinician, the optimal management of secondary PPH. So, look for the cause. If it is there, manage it accordingly. If not, then decide what should be done. And I think eminence and the experience matters most. And there are certain clinical evidences one should not forget. But remember, surgical management has got its own complications. So before resorting back to surgery, one must question that is medical management suitable for this particular patient. That should also be taken seriously, because the management overall from the systematic review showed that yes, it's pretty good. So in summary, secondary PPH is an important cause. Please don't forget, it's not the primary PPH only. Secondary PPH also is an important cause of maternal morbidity and yes, rarely mortality as well. The etiology is diverse, that's the problem. Basic resuscitation should be considered in certain situations, but definitely investigation is important to look for the cause, to tailor the treatment accordingly. Management, yes, medical, surgical, and radiological. The radiological techniques are coming, particularly when the medical and surgical treatments fail to offer any benefit to the patient. There is, as of now, minimal low evidence available to guide the management of secondary PPH. The diverse nature of the etiology and the acute presentation makes any RCT to design and to offer any help to the clinician. So what is expected, that future well-designed prospective studies are required to provide the clinicians certain guidelines to manage these unfortunate cases of secondary PPH. Thank you very much.
Thank you, Dr. Mishra, for such a elaborate talk. Secondary PPH is definitely a problem, and earlier everyone used to rush for a DNC, that there are retained product of conception, but you have very rightly said that it can be managed medically, because now the ultrasound is available and we can most of the time do the ultrasound and decide. And once we go for diagnosed DNC, it can remove the clot or the scab which was already forming and lead to further PPH. Therefore, we have to be cautious for it. And you have said very importantly that we have to send the products for histopathology to exclude choriocarcinoma. Thank you so much.
Thank you. In fact, if I'm allowed half minute,
yes.
I can cite one example of my patient, that the patient was fibroid with pregnancy, large fibroid. I did the cesarean section. She was all right. After 4 weeks, she came with massive hemorrhage to the extent of shock. I managed the patient. but I couldn't find out any possible cause. Ultrasonography failed to reveal anything. Then I sent the patient for pelvic angiography. It was done. No cause was identified. And then bleeding continued, but in a lesser magnitude. But the bleeding ceases automatically without any further treatment. Thank you very much. What I wanted to say, even without treatment, sometimes it resolves.
All right, thank you. Thank you so much. I request Chairperson to please come near to the photo booth. And all the speakers of the morning talk, please come on the right-hand side of the stage. Quickly. Meanwhile, let's proceed further.
I would like to invite the chairpersons downstage on the right side of the stage. Anjana Madam, Nibha Mohan Madam and Neeru Goyal Madam. Please honor the speakers with the mementos.
All right, we'll move forward for the session 2. Quickly, I would like to invite first our chairperson one by one. Can I please request Dr. Janmejay Mohapatra to please come forward, join us. Let's have a round of applause for Dr. Janmejay, please. Followed by Dr. Pratibala Sahai. Dr. Rita Sinha. Please, ma'am. Dr. Himanshu Roy.
A very good morning to all. I welcome you to yet another interesting session in which we have eminent speakers like Dr. P.K. Shah and Dr. Madhuri Patel, Madam. For this, we have equally eminent chairpersons, Dr. Janmejay Mohapatra, his Vice President-elect Pphcon, Dr. Preeti Bala Sahai, ex-professor and head RIMS, Dr. Rita Sinha, Madam, ex-professor PMCH and consultant MGM Hospital, and Dr. Himanshu Roy, pioneer of IVF in Patna and Bihar. I request all the chairpersons to kindly come to the dais. Dr.
Already on the dais.
Rita Sinha Madam is not there.
Thank you. Thank you. Good morning, everybody. The first speaker is our own Dr. P.K. Shah. He needs no introduction. Sir is well known to Pphcon, and I am privileged to introduce Sir. Sir is the Professor in Department of OBG, LTM Medical College, Sion, Mumbai, past President Pphcon, IIG, IFMB, MOGS, FTT, past in Indian College of Medical Ultrasound, past Chairman Imaging Science Committee, and so many and so many awards. Yeah, over to you, sir. Thank you.
Thank you very much, Janmejay, for your kind introduction. At the outset, let me thank all the organizers, especially Dr. Meena Samant, Dr. Amita Sinha, and the whole team of Bihar Obstetric Gynec Society and all the seniors whom I know for so many years. Good morning to all of you. And my talk is on management of iron deficiency anemia after PPH. Please understand very clearly what I am going to talk to you all on. Again, the same international standard remains: normal 11 or more, mild anemia 10 to 10.9, moderate 7 to 9, and less than 7 severe anemia. So obviously you're going to do hemoglobin when a patient has PPH, and you will put her in one of these categories. Again, you can send all the investigations for confirming the diagnosis like hemoglobin, ferritin, serum iron, etc., etc., etc. And you all know very well what are the standards to call it an iron deficiency anemia. What is important is that you have a choice how to manage this patient of iron deficiency anemia following PPH. Medical nutrition obviously doesn't work now. Deworming, oral iron therapy, and parenteral iron. If it is less than 7, obviously you have to give blood. So there is no controversy about that. But when you have between 7 to 10, what is best for that patient who is with you, who had PPH and now she has low hemoglobin. We all know the factors affecting oral iron absorption, and they include dose, status of the patient, form administered, stability in GI, gastric acids, elemental iron, which is given, and bioavailability. Now remember one thing, if you are given oral iron to this patient because her hemoglobin is less, and you repeat hemoglobin, if it has gone up by less than 1 gram percent in 2 weeks' time, she is the candidate for parenteral iron. Please do not stuff oral iron anymore. We all know the challenges from oral iron. Therefore, parenteral iron is seen to be an attractive option in treatment of iron deficiency anemia following postpartum hemorrhage.
Kindly maintain the silence. Go on, Dr.
GI side effects can lead to suboptimal patient compliance when you give oral iron therapy. So it's better that you give her parenteral. We all know what are the indications for parenteral iron therapy. Poor tolerance to oral iron, very important in our country. Poor absorption, non-compliant patient, again equally important. Moderate to severe anemia, and women on recombinant erythropoietin. What is important is, when you want to give parenteral iron, stop oral iron 24 hours before the therapy starts, and you can restart it after completion of parenteral iron after 1 week. What is most important, confirm that you are giving it to only iron deficiency anemia. Keep in mind all the contraindications for giving. What is the dose for parenteral iron? 2.4 multiplied by deficiency in grams per cent, multiplied by pre-pregnancy weight. How many of you remember which patient had what weight before she got pregnant? Forget about that. Whatever is the weight at that point of time when she comes to you, take into consideration that. But the most important thing is that for replenishment of iron stores, you have to give 1000 milligram, not 500 milligram as we were taught once upon a time when we were students and residents. Please remember this. So suppose her hemoglobin is 9, you want to bring it to 11. There is a deficiency of 2 grams. That means 2.4 multiplied by 2 comes to 4.8. Multiply by, suppose her weight is 50 kg, it comes to 240, okay, milligram, plus 1000 milligrams. So she needs to be given so much of iron. We all know about different generations of iron, and iron isomaltoside, that is injection I3. What is this I3? There are 3 I's. The first one is intravenous, second I is iron, and third I is isomaltoside, which is a new molecule which has come in the market. Actually, it was there, but it was not used. And the complex is very strong, just like ferric carboxy maltose. Now, suppose the hemoglobin is more than 10 but less than 11. Ferritin less than 100 nanogram per deciliter per milliliter, transferring saturation is less than 20%. Start oral iron, repeat hemoglobin after 2 weeks. If it is less than 1 gram percent, immediately switch over to intravenous iron. Please remember this. There is no place of intramuscular iron now. Anyone is giving intramuscular iron this August audience, please raise hand. No one. So IM iron is gone out of practice totally. Now, if it is severe, less than 10, obviously, but more than 7, straightway start with intravenous iron. You can give either iron sucrose, almost up to 10 doses, 100 milligram to 200 milligram, ferric carboxy maltose up to 1000 milligram, and iron isomaltoside, that is I3, you can give up to 1500 milligram. Remember this. This is one thing which you have to keep in mind. What is the importance of this carbohydrate shell? You see iron dextran, sucrose, ferric carboxy maltose. So what is this iron? So every parental iron is complexed with carbohydrate moiety which holds the iron till the iron complex reaches liver and spleen. Stronger the complex, safer is the parental iron because it will release less labile iron. Labile irons are free iron released from the iron complex after administration. Please remember this. Since these are free irons, they are responsible for effects like hypotension, during intravenous infusion, hypersensitivity, oxidative stress, cytotoxicity, etc., etc., etc. Labile iron potential is least with iron isomaltoside, as you can see here. It is maximum with iron sucrose. Read that line, which is the line with blue line. What is the maximum dose of intravenous iron that you can give? For iron sucrose, 200 milligram, ferric carboxymaltose, 1000 milligram, and iron isomaltoside, 1500 milligram. It's only intravenous iron with no upper limit of intravenous iron administration, but the manufacturers have given 1500 milligram as max. It is approved by US FDA in January 2020. This parenteral iron isomaltoside is absorbed by reticuloendothelial cells in liver and spleen. Splitting of iron complex occurs again by the reticuloendothelial cells in liver, and this iron binds to protein and forms ferritin, which replenishes the iron stores. Now, which iron is better? Iron sucrose came and we started giving it. Then came iron ferric carboxymaltose and FCM that we all have been giving now. And now this is the latest molecule. So which one is better? So let us compare. Sucrose, you require 4 to 5 visits minimum. Whereas when you have isomaltoside, you have to give only in 1500 milligram is max. Hemoglobin increase from baseline in grams percent was around 1.48 for isomaltoside compared to 1.19 in iron sucrose, whereas the proportion of responders with hemoglobin increase more than 2 grams per deciliter was 32.6% with isomaltoside, whereas it was around 20%. Median time for hemoglobin increase more than 2 grams per cent was around 26 days compared to 37 days for iron sucrose. Can be given to a maximum of 200 milligram iron sucrose, not more than 3 times per week, and doses must be at least 24 hours apart. Whereas you can give iron isomaltoside up to 1500 milligram in one visit. Now coming to what we have been using, the ferric carboxymaltose. Which molecule is better? FCM, when given in one sitting, ferric carboxymaltose, causes raised fibroblast growth factor, which leads to reduced phosphorus level, reduced vitamin D level, reduced calcium absorption, and all these will lead to hypophosphatemia. So it is almost 10 times higher chances of hypophosphatemia with ferric carboxymaltose compared to isomaltoside. There are no changes in vitamin D and calcium hemostasis with iron isomaltoside. And this is all evidence-based. I am not saying just like that. Each one has been shown and published. Analysis showed the using iron isomaltoside rather than FCM in patient with IDA would reduce number of iron infusions required to correct iron deficiency, thereby reducing the costs associated with IDA treatment and simultaneously increasing proportion of patients with IDA experiencing clinically meaningful hematological response. How is it superior to ferric carboxymaltose? We all know, single infusion, no hypophosphatemia. Iron isomaltoside up to 1500 milligram is administered with a dose of 20 milligram per kg body weight. Please remember this, 20 milligram per kg body weight. It's used in many other areas like oncology, cardiology, chronic renal disease. What about pregnancy? Is it safe? Yes. All these three, iron isomaltoside, sucrose and carboxymaltose, are category B and it can be given. The risk of serious or severe hypersensitivity reaction was lower with iron isomaltoside compared to FCM and iron sucrose. Again, this is published in 2017 International Journal of Transfusion Medicine. Results support convenience, safety, and efficacy of a single dose up to 1,500 milligram of isomaltoside for iron deficiency anemia during pregnancy and puerperium. What about postpartum period? Yeah. This is a very good paper which says that a single dose of I3 associated with a statistically significant and clinically relevant reduction in aggregated physical fatigue, very important, which we don't bother about. Once the patient is delivered, we feel as if our job is over. So this fatigue is reduced in all these patients, and it was shown that even the content of milk, the iron was almost 2 times higher with iron isomaltoside. One more in postpartum anemia, the study shows intravenous iron could be an attractive alternative to RBC transfusion. Please remember this, RBC transfusion. So if the hemoglobin is more than 10 but less than 11, you can give 500 milligram if patient is less than 50 kg, 1000 if less between 50 to 70 and more than 1500 if she is more than 70 kg. Total dose per week should not exceed 20 milligram of iron per kg body weight. Evaluate after intravenous iron isomaltoside after 4 weeks. What is the hemoglobin concentration? Iron isomaltoside should be infused undiluted or diluted in 100 cc of sodium chloride and not in 500 cc of 1 bottle of sodium chloride. Please remember this. We all know when to give blood transfusion. We also know what are the complications of blood transfusion. So, do not, you have a chance to use something which can replace almost blood in postpartum period. So, what does it summarize my talk? Intravenous iron use in women of reproductive age has increased rapidly. Isomaltoside is the only intravenous iron that can be given up to 1,500 milligram faster and higher hemoglobin rise. No test dose required. Possibility of providing full iron repletion in single infusion. Clinical and observational studies, no acute anaphylaxis or delayed energy, and it's safe, effective, convenient, low immunologic potential, low potential to release labile iron, does not appear to be associated with clinically significant phosphatemia, and overall it is almost half the cost of ferric carboxymaltose. Thank you very much, ladies and gentlemen.
Thank you. Thank you, Dr. Pphcon. You have demanded yesterday, कि ma'am, please give me 2 minutes time. So they have given 2 minutes time. Okay, thank you. Your talk was very nice. Thank you very much. Now I invite the second speaker, none other than Dr. Madhuri Patel. She is going to speak on conservative surgical management in atonic PPH. This is a very classical and practical topic. I think everybody will like it. I don't remember I don't know, but she is Secretary General and she is going to contest for the President Foxy. Okay, Madhuri? Thank you. and everything is on this flashing. Okay.
Such a wonderful and lovely words. Respected Madam Janmajaya, Himanshu, then I can see Dr. P.K. Shah, who just you heard him, Madam Alka Kripnani, who is going to, you are going to hear after my, Madam Shanti Roy, Madam, Anita Singh, Madam Manju Gita Mishra, of course, Vinita and all my dear friends. Very good morning to all of you. At the outset, I would like to thank Dr. Jaideep Tan, Dr. Meena, Dr. Amita and entire team of Patna for giving me this opportunity. You have been hearing lots about since yesterday. You had a workstation. Today, tomorrow, you are going to hear postpartum hemorrhage, and postpartum hemorrhage. Today, I am going to talk on conservative surgical management of postpartum hemorrhage in atonic PPH. So we all are aware that a PPH is a serious, life-threatening obstetric condition where we can lose mother and mother can end up with morbidity, and it has very high in developing countries. So each year, 14 million women suffer from PPH. Each year, 70,000 maternal deaths occur all over the world, and PPH contributes 27% of the maternal death. So look at in India, there are 2 to 4% occurs following vaginal delivery, and 6% overall, 8 to 10% occurs if following these deliveries. And it is high with the high risk factor. We know tone, trauma, tissue, thrombin are the causes, and atonic PPH makes 70% of the patient suffering from postpartum hemorrhage. Ultimately, what it causes? It causes hypovolemic shock, DIC, renal failure, hepatic failure, adult respiratory syndrome, and of course, maternal death. So let's look. Traditionally, all atonic PPH are treated by either medically, nowadays we call it emotive approach, mechanically, and ultimately radical surgical procedure. But since last 2 decades, we are with the surgical, conservative surgical procedure, and it has been used and is very, very successful. So what is the mode of action? It controls PPH, preserves reproductive function, avoid hysterectomy-related complications. So the approach of the atonic PPH for conservative management should be, it depends upon the clinical situation, skill of the operator, and technology available. So there are so many, methods. Manual removal of placenta. If patient does not deliver within 30 minutes placenta, then we proceed with the manual removal placenta. And if there is a part of, placental bit is inside of membrane, you have to do exploration, then only the PPH will be under control. Then we have brass suture, uterine and ovarian artery ligation, what you call as stepwise devascularization of the uterus, internal iliac artery ligation, COMOC MG, that is uterine artery ligation, along with the compression suture. Then uterine artery ligation with cervico-ischemic suture, that is for the placenta accreta syndrome, and uterine artery embolization. So this is a brass suture, all of us are aware. This is a simple, effective, relatively, and requires minimal expertise. And woman meets with the criteria, you can do Billinch only when on compression, bimanual compression, the bleeding decreases. Then only she will have, success of this Billinch operation. And there are many, successfully done, which is described by Cho, Hyman, and Pereira, were equally effective. And we are doing with many modified now condition where I will show you the video that, after the cesarean patient had a postpartum hemorrhage. And, you can do in any modified manner where it can compress the uterus. So now we are going in and out and, just tying the suture at the fundus. And, that can also compress the uterus. So you can see over here, and you can use your method whichever way you want to use. Initially, Billinch used to open the uterus and then take the CCs, but you can do according to your convenience. So now, the success rate of compression suture is achieved hemostasis in 76 to 100%. In the all these things, all 3 people who have started in the beginning, they gave 100% result. And in a systemic review, the overall success rate was 91.7%. Complications were not reported. Complication can include uterine synecdoche, ischemia, uterine necrosis, intrauterine infection, strangulation of the intestinal loop and abdominal content if you use non-absorbable suture. And Pphcon recommends, if your medical line and the mechanical treatment fails, then this is the first choice. You can go ahead with the atonic PPH. Now let us look at the stepwise devascularization of the uterus. It is reported in Egypt in 1960 and effective in 80% of the cases. So here we do uterine artery ligation, lower part, upper part, both the side, then lower part, both the side, and if it doesn't help, then we go with the unilateral ovarian vessel ligation and bilateral ovarian vessel ligation. So let us look at the uterine artery ligation. 90% of the blood supply comes to the uterus during pregnancy from the uterine vessel. So ligation of uterine arteries result into significant reduction in the blood flow to the uterus. It is a simple, fast performing technique, and Pphcon recommends Your medical line, mechanical methods, your B-Lynch, that is compression suture, they fail, then you should go for uterine artery ligation in atonic PPH. So here you can see the video where we are doing, after the cesarean patient had a PPH, so we went below 2 centimeter at the scar, incision of uterus, and 2 centimeter deep. It is a very, very simple procedure, and we all should know this procedure, which will be helpful in our practice. So now, ovarian artery directly arises from the aorta, and when you should do ovarian artery ligation, because after uterine artery ligation, the blanching occurs and the bleeding reduces. But if the bleeding does not reduce, then you have to go for the ovarian artery ligation, which arises directly from the aorta. Anastomosis with the uterine artery occurs in the region of the uterine ovarian ligament near the uterine surface. So this is another video where you can do uterine artery ligation, where you take a fallopian tube. Below that, the ovarian artery enters into the meso-ovarian, and there you have to tie. But if you can't do that, you can directly, ligate the infundibulopelvic ligament. So now we are with the internal iliac artery ligation. So experiments in the 1960 by Burschel ascertain that the effect of this internal iliac artery ligation is to convert the arterial flow into a venous flow. So stasis occurs and the clot formation takes place, and that is enough to control the atonic postpartum hemorrhage. It is effective in uterine and atony and many more conditions, but in uterine and atony, you have to do bilateral internal iliac ligation. Remember, it is less effective in placenta accreta and not useful in the uterine laceration. It should be done by the surgeon comfortable who is operating in the retroperitoneal space. Clinician must also consider whether this patient is fit for internal iliac ligation or not. Because many times what happens, patient is hypotensive, she is unstable, and still we keep on trying, uterine artery, internal iliac artery ligation. So that time you have to take a decision whether you should do a definite line of treatment or you have to still give some time for the internal iliac artery ligation. So this is, that it is at L4 level, common iliac artery divides into external iliac and internal iliac. And after 3 centimeter, internal iliac gives anterior and the posterior branch. These are the branches of internal iliac, and I am not going to talk about it, but I am going to talk about the procedure, what is called as direct method and indirect method. So once the patient lands with the PPH, what you are going to do, you are going to open the abdominal layers, peritoneum, or you are with the cesarean section. Can you mute the sound? I have to mute the sound. Okay. So after opening the peritoneal cavity, you have to deliver the uterus and take on one side and do the surgery on the other side, where we have to open the peritoneum at the round ligament and the fallopian tube in between and extend it laterally and identify the external iliac artery, which is on the psoas muscle, and go upward, that is cranially, and try to locate your internal iliac artery. So here we are trying to locate, we are going upward, you have to take care of the ureter, which should be retracted medially, and now we are with the bifurcation. You can see over there, internal iliac and the external iliac. Now there is 2 methods, as I mentioned. Direct method, which we are doing, is a direct method, and you remember that the internal iliac vein is posterior, a little lateral to the internal iliac artery. So when you are doing a direct method, you may puncture this vein, patient will have torrential bleed, and patient can die on the table. So for that, we have another method which we are doing now is the indirect method, where we are passing the mixture below your common iliac artery. You just observe this, and now mixture is passed and we are feeding the thread. And remember one thing, you should always open the capsule. If you don't open the capsule, your stitch will not be proper. So this mixture is passed and the suture is, fed, right? And now you see what is the indirect method. Here in indirect method, now the external iliac artery, we are going below that, which is relatively safe. And, then taking out, and it just see the stitch is on the internal iliac artery. So to avoid the puncture of the internal iliac vein, we can opt this method, indirect method, and take your thread 3 centimeter below the internal iliac artery bifurcation, and there you can tie it. So certain facts about internal iliac artery ligation. Femoral pulse should be palpated before and after ligation. You can use absorbable suture or non-absorbable. It has no significance. Then you can do unilateral broad ligation in a broad ligament hematoma. Then after ligation of internal iliac artery, the collateral circulation happens in 45 to 50 minutes. By that time, your purpose is served. Various studies have reported that internal iliac ligation was effective in 75 to 81 to 190% of the cases, and there was no problem with fertility and the pregnancy outcome. So now this is a COMOC by Dr. Mahesh Gupta Stitch, who is a national coordinator of this conference. I had obtained his PPH conclave in last year in Gandhinagar. It was fantastic, and this is again he's performing, he's doing very well with the Patna team. So here we do compression suture with occlusion of uterine artery. What he has reported a paper in our journal in 2020, and this forms a dual action or to control the postpartum hemorrhage, and he has reported in 3 cases where the postpartum menstrual flow and breastfeeding were normal. Ultrasound confirmed that the endometrium and the ureters were normal. On hysteroscopy showed normal uterine cavity in all 3 women, and 1 patient subsequently delivered by C-section after 6 years of these stitches. Now there is another uterine artery ligation with cervico-ischemic suture. Again, he must have shown you yesterday on the workshop where he does for the PAS, that is placenta accreta syndrome. We used to end up with the hysterectomy, but now you can use the conservative line of treatment in these cases, where we deliver the baby, and after that we do uterine artery ligation, and then you take a cervico-ischemic stitches, anterior, posterior, again come back, anterior, posterior, again come back. Tie it and then tie them and then deliver the placenta. And it is noticed that atonic PPH, you can treat this condition, use this operation, and you can save the uterus. Now role of selective artery embolization. If you have facilities and if you are diagnosing such patient, before delivery, you should send them to the tertiary care center where the facilities are available. So the patient, past patient, you can send them. So before operation only, they can put a catheter, and they can put an endo balloon where they can occlude the vessels. And you can also use for alternative obstetric hysterectomy, bleeding persisting after hysterectomy, bleeding due to cervical or vaginal laceration. So procedure, all of you are knowing that you catheterize from the premolar artery, reach up to the uterine artery, and then if it happens, patient ends up with postpartum hemorrhage, just put the endovascular balloon for temporarily, which will occlude the vessels, and patient will be, relieved from the postpartum hemorrhage. So there are success rate has been reported 90% and low complication rate. And Ojala et al. Has described that in cases of patients who underwent embolization of the uterine arteries and aborted hysterectomy, close to 80%. So that is very, very high. And complications are minor. They are 8.7%, and usually there is a low-grade fever. Some studies have documented resumption of menses and even pregnancy after this procedure. So to conclude, atonic PPH is a major cause of maternal mortality and morbidity. Conservative surgical procedure is defective, preserves fertility, and prevents hysterectomy-related complications and consequences. If situation demands, one should not hesitate to perform obstetric hysterectomy. Obstetrician should expertise in all these surgical methods. Timely surgical intervention reduces maternal mortality and morbidity tremendously. Yesterday I was not there, so I would like to say something about this postpartum hemorrhage, where we are carrying out a leadership development initiative for treatment of the postpartum hemorrhage. This is a Pphcon project, and this time we are doing, yesterday we did in Patna. So what is the partner is Pphcon, funder is Bill and Melinda Gates Foundation, and which countries they have included is India, Bangladesh, Ethiopia, Kenya, Nigeria, and Pakistan. The duration is for 4 years. We started with Dr. Rishikesh Pai, and you can see in the photo, myself and Dr. Rishikesh Pai were there in London to understand what is this project. And now so far, what is the aim? That is called a Leadership Development Initiative. We have, aim is to strengthen the leadership skill, increase adoption of maternal and newborn intervention, address the barriers, building a gender transformative. Means whoever we have selected 50 gynecologists, they are gender equal. But in our branch there are more females, so more female you will find in this project. And what is the aim? They gave us 4 projects. One is magnesium sulfate in prematurity, 1 minute. Magnesium sulfate in prematurity, then corticosteroid in prematurity, then they asked for parental use of iron in anemia, and tranexamic acid, what we call as EMO2 initiative, and we selected these two, EMO2 and the anemia, because they go hand in hand to control the atonic postpartum hemorrhage. So far we launched in 2023, 50 letters across India have joined, barriers assessment has completed, evidence-based curriculum created, data collection tools and reporting formats prepared, leadership training, empowerment series 1 completed, gender training and orientation completed. So this is the advocacy and training in full swing, FemTech 4, AICG 24, and now in Patna. And I must say, to conclude, reset, refocus, readjust, restart as many times as you need to. Just never give up. Let us ensure no mother dies of postpartum hemorrhage.
Thank you.
Thank you once again.
Thank you, Dr. Madhuri. Nicely, I think, covered all options of the surgical management. I remembered last month you were in Ranchi. I was your chairperson, and you have delivered a cesarean section. So it was very nice lecture. Oh, so thank you, organizers, that you have given me this opportunity for chairing the session. Himanshu, you will say something?
No, it's all right. Thank you so much.
All right, thank you. Let's give a round of applause to our chairperson also and both the speakers.
All the speakers and chairpersons for this session. I request them to kindly come downstage for felicitation and memento distribution.
All right, with this saving time, I request we'll start the next session. And I would like to request our chairperson to please come on dais. Can I request Dr. Mahesh Gupta to please walk in towards the desk? Dr. Mahesh Gupta. Dr. Vinita Singh. Dr. Amita Sinha, the leader of this conference, one of the leader. And Dr. Mini Anand, please. Now I request the chairperson to please invite the first speaker, Dr. Alpa, please. Dr. Alpa.
Very good morning to all of you. At the very outset, I would like to thank organizing chair, Dr. Meena, and organizing secretary, Dr. Amita, for giving me opportunity. The speaker is none other than Dr. Alka Kriplani, and who can forget her as a very dynamic and very energetic Pphcon president. So regarding Madam, she was as I said, she was Foxy president in year 2016. President GESI 2011 is still continuing. President DGES 2014 to 2016. President AOGD 2013 to 14, Editor Asian Journal of Obstetric and Gynecology, awards many, 47 awards, and she is Padma Shri Dr. Alka Kriplani, Madam. So, Madam, over to you, and she is going to speak on past surgical management.
At the outset, I must thank the organizers, Dr. Amita and Dr. Meena, and whole Patna team, and the August gathering sitting here, the dawns of Patna, Madam Manju Geeta Mishra, when we were young, she was like this, she's still like this. Dr. Anita, Dr. Shanti Roy, Himanshu, and all dear friends from Patna, it's an absolute pleasure and privilege to be here with you all today. Can you tell me what my time, because I have just few video clips of my work to show.
17 plus 2 plus 1.
They said one speaker has opted out. I don't know, it's up to you. So, we all know, all those who are into active practice of obstetrics, they all know this nightmare when you have to operate a case of placenta accreta, because there are so many complications and we all have witnessed all of them. Since time is come, it may be diagnosed at delivery, so it may go undiagnosed. Or in the night, a poor resident gives a call, Madam, it's like placenta accreta, patient came in emergency. That situation also arises. A very good solution is deliver the baby by classical cesarean, close her up and send, or send her like that close. So that is a very good option. But usually it happens nowadays, our radiologists are so good, they diagnose it. It is a scar ectopic. If it goes undiagnosed, it becomes placenta accreta. So multidisciplinary team is very important to give results. All these issues, timing of delivery. Now, my topic is surgical management, that too obstetrical hysterectomy. So I am going to, in the next 15 minutes, just show you some videos of our work in which we will discuss. It's very important in our center, whenever you give spinal, because surgery takes long, you might have to give general. Position is very important. We always operate in low lithotomy. Many a times you have to go and find the limit posteriorly. So that is called as posterior approach, through which we deliver uterus or remove uterus. Skinny, these things I think I'll discuss during videos. This is an important. If you are going to do hysterectomy, do not give oxytocin, because you don't want the placenta to separate. Once placental separation starts, patient starts pouring. Giving tranexamic acid is a very good idea. All evidence is there that if you give before start of surgery, blood loss may be little less. So these are important issues. Otherwise, let us come to the... So ultrasound or MRI. If the patient usually comes to us with diagnosis of PAS, and usually those who come to us are 3 and beyond. 3 means it is perforating the serosa. So this is one such patient. Always keep enough blood, open with midline vertical. When life is at stake, going cosmetic doesn't make much difference. These are usually 2-3 previous cesarean. Remove all adhesions. Till you touch the uterus, she is not going to bleed. Keep all safeguard, all precautions, then deliver the baby. Baby's IQ is very, very important than the blood. So deliver the baby. Always do classical cesarean section if you are going to do cesarean hysterectomy. And be away from the placenta. You see, sometimes they bleed. You feel like jumping out of window or cursing yourself, why did I take gynae in a patient like this? But keep your cool, otherwise your juniors will also feel the same way. Keep on doing, believe me, God is great, He is with us. So, upper segment classical cesarean away from placenta, don't detach placenta, put the cord in, suture that. Then start your hysterectomy, exteriorize uterus and lift it out of abdomen. It will compress uterines. And these are, I don't think it matters that having advanced bipolar, ligashore, this, that. It is your understanding of tissues and skill which saves your patient. So this is advanced bipolar cautery, which, and don't make blind clamps. Take windows of tissue like you see with the fingers so that you don't hit a major vessel. Don't go too near to uterus. Otherwise, once it opens up, it's very difficult to control bleeding. And you will see the lower segment often is 2/3 the size of upper segment because whole baby was lying there, whole placenta was lying there. So you have to painstakingly. I think the most important is learning how to dissect the bladder. MRI always, often overdiagnosis bladder is involved, and we have seen in our practice hardly with increasing experience you open bladder, because if you can find a plane between bladder and there are big vessels, they start pouring, you start putting clamps blindly, that is the problem. Keep patience. You will see how badly the bladder is stuck, but gradually being near to uterine serosa, not hitting it. The problem is we fear bladder, so we put too much towards uterus, and once a coagulum gets disturbed, placenta gets opened up, then it bleeds torrentially. So be in the correct layer. Keep on giving good traction, you see, on the uterus. Keep on dissecting the bladder down. And it doesn't matter much whether you are taking uterine beforehand or afterhand, it's the dissection of the bladder. Actually, all those placenta accretas who are in the lower segment after previous cesareans, only problem is the bladder. And it is not that you ligate internally like a uterine, it will help because the blood flow is coming from the pelvic anastomosis of vessels, it's coming from below. So again, you see 2/3 of the lower segment. Keep on doing. If she bleeds, it's just the pressureless. Have a team. Have a good assistant. So that is very important. A teamwork is very important. Your anesthetist knows, your colleagues, your juniors know, and then detach. We believe in removing, if patient is stable, doing complete total hysterectomy, and you will see, I mean, see how placenta gets torn because it is up to the serosa. This is the removing the cervix, that is optional. But in placenta percreta, if you can reach the lower border, unfortunately colleagues give very low incision, or if accreta is involving the cervix, then that case is going to create difficulty. I'll show you a video. Uterine vessels are perforated by placenta. So these cases are difficult. If your good MRI or ultrasound can tell you beforehand, take special precautions. Lower limit, if it can be reached, case is simple. And the rest is like closing the vault, like you do in routine. We always keep right angle. Satinsky clap helps you a lot in certain situations. Always keep it, it's a cheaper thing. Now this is a patient, no, time will finish, so I'll just, I used to think, and patient used to come from far off, from Singapore, from these countries, that we will get placenta accreta done at All India Institute by Kriplani. Still it is happening. And I used to say, okay, you come late and you stay somewhere and I'll operate you. But see, this booked patient with me, and number of times it has happened in Paras Hospital. She came to me and we booked her, we told we will do cesarean at 34 depending on situation. One night at 31 weeks, I get a call, patient has come collapsed in casualty. I said, what is it, madam? Your booked case of placenta accreta. We just ran, 3 liters of hemoperitoneum was there. Patient was pulseless, BP-less. We just wheeled her into theater. The placenta had perforated her right uterine artery, it got opened and it was bleeding like this. So again, you have to relieve hemoperitoneum, arrange lot of blood, you don't know how much she is going to bleed. Take out the uterus from abdomen. We were not able to control the uterine artery. And as Dr. Madhuri, very experienced obstetrician, told you, don't waste time in searching vessels. Minutes count. Patient will go in 10 minutes. Immediately, this is our way, because doing hundreds of myomectomies, we have learnt tourniquet. Simple Foley's catheter, tourniquet, ligated the uterine artery. Then once the blood flow, blood loss is controlled, torrential bleeding is controlled, then you can take your time and do. So we were not able to, pinpoint the bleeder. So we did, and all my friends, whenever your patient, this tourniquet really helps in our myomectomies. We remove 40, 50, 80 fibroids. We just put this tourniquet, and then it becomes so bloodless. It is a temporary way. It is a very nice way. And you have to learn dissecting bladder. See how placenta is popping out. Her MRI said beforehand that the bladder is involved. When she came exsanguinated, there was no. If you open the bladder at the fundus, it hardly makes a difference. Bladder is a very, very forgiving organ. So you should not at that time think the bladder I have to save. Rather, if it gets opened at fundus, you have the margins, you have the other ways, and you can always. But with increasing experience, chances of opening the bladder are low. MRI says it is involved. I'll show you nice catheterization, ureteric, I don't think it helps, and bladder. So these are the ways. Then don't think the patient you will give baby and do. This patient came in emergency with dead baby. I don't know whether you will comment what I did right or wrong, but this was the patient. Lady came with IUD, and number of times now it has happened, it was not previously, that they come we used to think placenta will never separate and patient will, right, it's working, it's okay. So this placenta accreta was diagnosed. She came with 26 weeks dead baby. So I thought that it will be easy to dissect the bladder if because of the baby lower segment is stretched. So I started doing hysterectomy like that. And as I said, one step wrong, she will start pooing. You have to be little away from the uterus, because the otherwise 400, 500 cc or mistake, she has to, it costs that much. So we kept on again dissecting. The bladder, to my mind, is the most important step in cases where bladder is supposed to be involved or too near, or it is 3A and beyond. Rest of the procedure is okay. You get placenta accreta after myomectomy, you get placenta accreta after IVF cases, and if they are high up, posterior wall, it doesn't, 100% of time we can save the uterus. These cases, see how the placenta is just up to the serosa accreta, and once placenta opens up, it bleeds like anything. In such a situation, if it has got opened up, remove it fast. Remove it fast, and this is the Foley's bulb very near. But if you can identify bladder, we haven't opened bladder in this case. It was all the time we were thinking it will get opened. And this is what? Be on the uterine serosa, but not into the serosa, because once you, and blood vessels will keep coming. You have to be very careful and diligently, step by step, take baby steps while you are controlling bleeding. Don't get upset seeing the torrential bleed. God is there, and this is what? This is just the serosa of the bladder. Then I am suturing it, and at the end we are checking, and the bladder did not get open. But if bladder gets open, suture in 2 layers, it's a very forgiving organ. But often bladder is not involved. Very rarely I have seen that it goes beyond and perforates into the bladder. Then we have to resect that part of the bladder and then suture the margins. So these are the interesting cases. The next question is when there is massive hemorrhage. All of us have witnessed that. What all you can do, if your brain is tuned, if we have done these drills, then you can put balloon tamponade. I think Nalini Mishra, my dear friend, was there yesterday. We use her balloons. She came to my center. She taught my staff how to make. They are as good as Bakri balloon. Devascularization, Dr. Madhuri has taken. Internally, like artery ligation does not help. At All India Institute, we did big projects. Ultimately, I realized it is your understanding of anatomy. Internally, like may help, may not, and it requires so much of paraphernalia. And after that, you have to heparinize your patient. Remember, you put clamps, you do this. Doing heparinization, you don't feel comfortable in such people. So everybody has, everything doesn't work in everyone's hand. So we do just surgical way. We have stopped doing internally like ligations. We have stopped doing aortic clamping, because if you give me time, I have such nice stories to discuss with you about aortic clamping. Devascularization, again, I think I'll just show. Dr. Piley, I respect him a lot. Whenever I meet him, I get inspired. I have bought his clamps also. I don't have the courage to, he doesn't dissect aorta, and he says it's so simple to put it. Aortic clamping, commonly like RT clamping, dissect the aorta and clamp, don't dissect the aorta then clamp. All these methods are available to you, but it depends on your experience and your expertise. Pelvic tamponade is very important. Anybody can do it. And these are very nice ways. You just give an incision posteriorly, put this Bakri balloon or our Nalini Mishra's Chhattisgarh balloon that works so well, and then wrap with some gauze and put a saline bottle so that with the pressure there is pelvic tamponade. These are all ways. Again, we don't fancy using them because it is post-op, you may have to open up. Internally, like there is good literature, positive and negative on both. Then nowadays they say don't do radiologically, you can do ultrasound guided aortic balloon inflation. At All India, all these things were tried, but everything has its advantage and disadvantage. A very important thing is when I'm still in Gurgaon, many medical colleges like Maulana Azad, my colleagues used to say, Madam, we remove the baby by upper classical, we close the incision, we never go for one-step hysterectomy, we leave the patient after 3 to 6 to 12 weeks, then we do secondary hysterectomy. There is very good literature, large trials are going on, have been done internationally, whether when you are caught in a situation when your patient is bleeding, you open up placenta percreta, whether you remove the baby and do cesarean hysterectomy at the same time, or you remove the baby, close the patient, tell her, be careful, get beta HCG, get ultrasound, be near to hospital, come after 4 to 6 weeks, logically vascularity will be less, and we will do secondary hysterectomy. People have also done after 4 to 6 weeks laparoscopic hysterectomy. All these things are available. I think my time will be up. Otherwise, I have lovely literature. Those who have left, I don't believe in leaving, but my colleagues, and I have all those stories to share that sometimes a patient comes in the casualty, placenta percreta, delivers her placenta and goes home without any blood transfusion. But there are patients who come in septicemia, frank septicemia infected. There are patients who come with torrential hemorrhage, and I know a patient who entered casualty and could not be resuscitated. So when you are leaving, you are taking a chance, and the patient should be that much educated that she should be near the hospital facility, and all these complications are to be kept in mind. So immediate versus delayed hysterectomy is a very good. Since I was very much keen because these Gulf countries, patients do not accept hysterectomy very fast, and they keep on getting 3, 4, 5, 6, 7 cesareans. There is a very nice doctor, I thought he will be here. These people are doing conservative management. We also do, but conservative. Conservative means placenta accreta percreta, you have removed the baby, now same sitting, we repair. Can I show one video of 2 minutes?
Yes.
Yeah, we added 2 minutes.
But my has
2 minutes added.
2 minutes? Okay. So triple P procedure, we all have modifications, and this is our modification. The patient was having previous cesarean, dead baby, they said bladder is involved, then I got her cystoscopy done. ये रुक गया क्या? cystoscopy done, and whole bulge was there, you see. Whole bulge of placenta was there posteriorly. She didn't have any alive baby. She was very keen to save her uterus. Not every patient can be promised that I'll save your uterus. It has to be not that bad a case, especially 3C, when it is into parametrium and uterines, it's very difficult. But if it is up to serosa, this is the way in routine we save uterus. We never promise, we always take the consent. But then if we plan beforehand, then give a transverse incision above the upper margin of placenta, because that placenta accreta you are not going to separate. You are going to remove the uterus along with the placentation and then suture the rest normal.
Hello.
So this was our way, and only thing you have to be very good in stepwise devascularization. I don't know whether it is in this video, tubo-ovarian branches, uterine, and sometimes this was a patient where what you saw in the bladder was the focal placenta percreta. But bladder mucosa we could save opening the bladder, because if you see, these are the tourniquet, we keep on advancing our tourniquet. It gives such a good bloodless field that you can do your work. The problem is when everything is bleeding, you are applying clamps, then ureter and bladder are, at risk. So this is what, and remove the part of uterine musculature where placenta is embedded. In a minute you will see there is a big focal placenta which is going up to the bladder, and this is what stepwise simple devascularization. Always take helical sutures, don't go very lateral, whatever is the blood supply coming. The problem is sometimes blood supply is coming from pelvic base, from the vaginal arteries and all. That becomes difficult. See how it is devascularized. And this is what tubo-ovarian. Save the tube. If there is lot of supplies coming from the ovarian, you suture these ovarian vessels, and this is what? This is not ovarian. This is tubo-ovarian, branch of ovarian and uterine. So it devascularizes it very well. Patient can have pregnancy and delivery after that. Again, these are, now you will see a big part of placenta I'll remove. See, this is what is, which was coming through the bladder. So focal accreta rest you could see, and we also do internal iliac ligation, but whenever you feel that there is lot of oozing from the bed, otherwise it may not be. Go by the side of round ligament, go below the bladder, then come up. It is easier to avoid injury to bladder and separate bladder. I think before they ring another bell, these are all our ways of doing accreta, how to do posterior accreta, fertility outcome, people become pregnant after that, but there may again be accreta. It is an obstetrician's nightmare. Incidence is rising. Don't give very low incision. We used to think it's a fashion, because in that part of cervix there are no decidua. So next time the placentation occurs there, and then it becomes scar ectopic and ultimately placenta accreta. So scar should not be on the cervix, because nature has not given proper decidua there. Multidisciplinary team is important, but with increasing experience, you may require less and less. Good blood transfusion facilities are a must. You don't know how much you will require, and antenatal diagnosis helps in making, but I saw you these cases coming in emergency, and surgeons experience, centers which are routinely doing, and all our medical college colleagues, they are so proficient because they have to do that. Patients keep coming in emergency with placenta accreta, and these are the ways. Don't promise the patient you will save uterus, but if it is not a very severe degree, it should be less than 50%, and it should be away. The placenta which is away from the os, you can reach the lower limit. You will be able to manage very easily. In a patient where placenta is below the cervix, there the problem occurs. And we believe in doing total hysterectomy. It doesn't make a difference up total. When life is at stake, it doesn't make much difference. And thank you very much for the invitation and patient hearing.
Thank you, madam. We all know that PAS is a nightmare for us. And you have shown such a wonderful videos how to manage surgically. I think the liberal longitudinal incision, classical cesarean section, and I think proper planning before going for any operation, any surgical interventions, we should do a proper planning. So thank you, madam, for such wonderful presentation.
Please invite the next speaker.
Madam Alka Kriplani.
Oh, Dr. Mahesh, he is the king of PPH and placenta accreta. I always feel very sorry on your invitation. I could not come. I feel very guilty whenever I meet you, but there were some family reasons at that time.
So, in the now lately in all placenta accreta spectrum surgeries, we generally conserve the uterus. It was a very old theory that don't touch the placenta, but it is not so. Now, with the technique what the madam had shown, majority of our patients we can conserve the uterus, we can treat the hemorrhage, and the patient will be all right. So in all cases, there is no need to do obstetric hysterectomy. So one should not enter in the operation theatre with the prefix mind that I will go for obstetric hysterectomy. You take the decision of obstetric hysterectomy during cesarean section and do accordingly. That is the only take-home message.
Yes. When it is into cervix and parametrium and uterine, those cases, by and large people who have 2 children, so I respect your thinking. You can save, it requires much more skill than doing hysterectomy.
Can I request chairperson to please invite next speaker, please?
Now we move on to the next talk, and it's my honor to invite next speaker, Dr. Anita Singh. Madam is Chief Consultant, Jyoti Punj Hospital and Jan Chikitsa Hospital, President AOGS BJ, Chairperson Bihar Chapter is IAG, past President POX, and past BP Foxy 2020. Madam is going to talk about preventing and managing urinary tract injury during surgery for PAS. Madam, stage is yours.
Thank you, Dr. Amita. Good morning. We have all seen such beautiful videos of such serious patients. It was quite a good learning for all of us. I am going to concentrate on the urinary tract injuries that do happen while you are doing surgery for placenta accreta syndrome. We all know that there are different grades of placenta accreta syndrome. If it is only attached into the myometrium, it is increta. If it has pervaded into the myometrium, then it is increta, and if it has reached the serosal layer, then it becomes percreta. There are different grades again, and this grade 3D, 3E are the most serious ones. As we have seen in the videos, they infiltrate the uterine artery, bladder, and the parametrium and broad ligament sometimes. So there are several risk factors. We all know: previous section, placenta previa, elderly women, multiparity adenomyosis, previous any uterine surgery, and previous curettage may even lead to placenta accreta. Diagnosis has already been discussed in the morning. Chiefly it is by ultrasound. In some cases we have to refer the patient for MRI if there is doubt about infiltration laterally beyond the uterine wall. In first trimester, there is always a suspicion of a scarred pregnancy, and that turns out later on in PAS. Anatomy scan actually confirms the diagnosis, and later on we revise the extent. Ultrasound images I am not going to discuss. Options of management is being taught to us since yesterday: hysterectomy, partial resective techniques as beautifully shown by Dr. Alka Kriplani, and interval hysterectomy. She has discussed in detail what is the benefit and risk of this choice. Why there is increased risk of urinary injury in PAS? Because there is extended remodeling of lower uterine segment. It doesn't look like the one which looks in normal pregnancy. There is massive neovascularization of the whole area and the surrounding pelvic tissue. There is fibrosis and lack of cleavage between uterus and bladder anteriorly, along with extensive neovascularization. And the specialty about this neovascularization is that these vessels do not have media. So these vessels do not contract on their own. They keep on bleeding, and unless and until you tie these vessels, even after cauterization, they start bleeding again. So sometimes actually it is very difficult to control bleeding even from the very small vessels which are not even visualized casually. So that is the main point of recurrence of bleeding, and sometimes you may have to do re-laparotomy also. There is bulging of part of placenta anteriorly into the bladder and laterally into the broad ligament and parametrium. So bladder injury usually occurs while we prepare the bladder flap during hysterectomy. When we proceed for doing hysterectomy in these cases, and you start preparing bladder flap as shown in the videos, there is chances of opening up of the bladder. And in the ureter, because of the excessive hemorrhage and poor visualization of the area, once you start clamping uterine artery, there are chances of taking up of ureter in that clamp. And in severe degrees of pus, as the placenta is extending beyond the boundaries of uterus into the broad ligament, it becomes very difficult to identify where the limit of this placenta ends and where you should put the clamps, and then you are likely to injure the bladder. Similarly, at the angles, there is lot of bleeding, and you apply the clamp, and sometimes you pick up the ureter along in the clamp and tie it along with the suture at the angle. Higher the grade of this placenta accreta syndrome, there are more chances of injury to the urinary tract. And the common urinary tract injuries are cystotomy. You may have to do it intentionally if there is no separation between bladder wall and the placenta. Then you might have to cut some area of the bladder wall along with the hysterectomy, and that is intentional. Sometimes while separating the uterus from bladder, it can get opened up unintentionally. And as we have seen that even if you open up the bladder, it is usually at the dome of the bladder, and you can very easily repair it. That is not a big issue. But ureteric injuries, if it happens, that becomes really difficult for an average gynecologist to repair and go beyond it. But sometimes patients come back if the injury is not recognized on the table, not repaired well. Patients do come back with fistulas, ureteric as well as vesico-vaginal fistula. So you can see in this diagram that how much this bladder is near the anterior uterine surface, and the green line shows the dense fibrosis in cases of placenta accreta syndrome because of the placenta infiltrates into that area, and even it reaches into the bladder wall. Similarly, here we can see the relationship of ureter with the uterine artery and the angle. And if there is torrential hemorrhage and extension of placenta beyond the lateral boundary of the uterus, it can be caught up in the clamps either at the uterine artery level or at the level of the angle of the uterus. So types of urinary tract injuries actually depend upon the type of surgery that you are doing, hysterectomy or conservative management. Are you doing a planned surgery? Are you going for an emergency surgery? And what is the severity of this spectrum disorder? Is it accreta, increta, or is it percreta? The ominous ultrasound findings or MRI findings where you suspect that you are likely to do urinary tract injuries are hypervascularization of uterine bladder interface and vascular invasion of placenta. If you see these two findings in your ultrasound report or MRI report, you should become alert, and if possible or ideally, you should keep an urologist friend with you while you are planning to go for the surgery if you are going to do a planned surgery. Looking at the incidence of urinary tract injuries, overall incidence is 15%, out of which cystotomy in 13.5%, and ureteric injuries occur in about 2% of the cases. But if you see the type of placenta that you are dealing with, and majority of the cases that we are dealing are placenta percreta, we are discussing our placenta percreta, in those cases, there are up to 40% chances of injuring urinary tract somewhere or the other, because all the surgeons doesn't have the capacity like Mahesh Gupta and Dr. Alka Kripalani. So for an average gynecologist, urinary tract injuries in saving the patient life becomes the second problem, and so the incidence of injuries in placenta percreta is quite high by a common gynecologist. Type of surgery and urinary tract injury, as I have said, in hysterectomy, there are chances of around 20% causing the injury. In conservative management, less chances of causing urinary tract injuries, only in the tune of 12%. It was a study done in India, and A.G. Radhika has done this study on placenta accreta syndrome. I was a part of that study. Dr. Meena was also a part of that study, and that was published recently in 2022. And there were total cases were 75. Urinary tract injuries were reported in about 20%, bladder injury in 15, ureteric transection in 1, and all cases had undergone hysterectomy. There was no report of any conservative management in this placenta accreta syndrome. In my place, I have done 21 cases, all pass grade 3, and total urinary tract injuries was 3. All cases are cases of where grade 3D or 3E. Cystotomy was there in 8 cases, out of which 2 cases developed vaginal fistula, ureteric ligation 1, and as I said, 2 vaginal fistulae occurred. This patient had come with frank hematuria, and she was diagnosed as a case of pass grade 3E, managed by total hysterectomy and partial bladder resection and reconstruction. But as the part excised was very near to the 2 ureteric fistulae, later on this patient developed vaginal fistula. And you can see how the bladder is invading into the placenta, is invading into the bladder. Case 2 was case of IUD with chorioamnionitis. Previous cesarean had been done for IUD and chorioamnionitis. She was past grade 3. Elective CS was done at 35 weeks. Placenta was attached on right lateral wall in lower segment, infiltrating the broad ligament and parametrium. Hysterectomy was done with complete removal of placenta. In post-operative period, oliguria developed within 12 hours in spite of well-maintained PP and pulse, and then suspicion of ureteric ligation on one side, and she was having not complete anuria, she was having severe oliguria. And then she was opened up, and the suture on the right-sided Macan ligament was released, and the patient started pouring urine from that side, and she got all right, nothing had to be done. So these things can happen while saving the life of the patient on the table. Sometimes you do these type of mistakes if not well prepared and well trained. So this is the picture of that patient that I did. Again, there was another patient who came at 12, only at 12 weeks of pregnancy. She had medical termination at some place, and after torrential hemorrhage, the procedure was abandoned. The patient was referred to me, and I had to do an emergency hysterectomy upon her. There was unintentional cystotomy, and the part of bladder had to be excised. And this patient, this is the same patient who developed vaginal fistula. So how to avoid urinary tract injuries in past surgery, tips and tricks. Ligation of round ligament should be done as close as possible to the pelvic wall. Dissection from round ligament towards midline should be done. Retroperitoneal dissection should start from above, from the normal area. You should proceed downwards. Dissect the ureters from above and displace it laterally. The creation of retrobladder tunnel, we have seen in the video, should be done very slowly and securing all the blood vessels which come in between the bladder and the anterior uterine wall. And gradually you should try to find out a correct cleavage plane between uterus and bladder, which is very crucial if you really want to save the patient and save her from getting injury to the bladder. And in difficult cases, one should start dissecting from below, from the paravesical space, and go upwards gradually to the area where there is lot of adhesion, and then you may be successful and find the correct cleavage in between the two organs. Always prefer intentional cystotomy if required and excise that particular area which is invaded by the placenta. Never hesitate in putting in ureteric catheter if you require and if the cystotomy has extended very near to the ureteric margin. Proper repair of cystotomy wound should be done. Methylene blue bladder filling test is quite good if you want to make sure about your repair of bladder. In some cases, like where there are chances of lateral extension of placenta, preoperative ureteric catheterization might help. Proper postoperative bladder care is very important, and indwelling catheter should be left for 2 weeks. So, in management of urinary tract injury, identification of the injury or apprehension of the injury is important, and after repairing bladder methylene, even for diagnosis, if you are in doubt, you can put in methylene blue and see. Ureter, if the bladder is open, you have got doubt about ureteric ligation or excision, you can put in ureteric catheters and confirm. Postoperative cystoscopic ureteric catheterization can also be done, and repair of the ureter especially should preferably be done by a urologist. If urologist is not available, then only you should try yourself. Bladder should be repaired in 2 layers as shown, first layer continuous and second layer by interrupted sutures with Becquerel 20. Ureter minor injury can be managed by negotiating DJ stent and keeping it for 3 months and later on removed cystoscopically. Transected ureter has to be repaired over ureteric catheter. If the transection or injury is very near to the bladder, then you can implant the ureter into the bladder. Sometimes you might have to prepare a Boary flap and implant the ureters in that. So the prerequisites for prevention and management of past injury to avoid bladder or ureteric injuries, antenatal diagnosis of all these cases in detail, keeping hemoglobin of these patients above 12 gram%, timely refer to a tertiary care center, elective surgery around 34 to 35 weeks with 4 units of PRBC, FAP and platelets in hand and more readily available to you. Team involvement of senior experienced and well-trained obstetrician along with anesthesiologist, urologist, neonatologist should be there, and the facility with availability of ICU and NICU units should only take up these cases. So the pearls of wisdom are 4 P's. Preparedness, you should be well prepared for this surgery. Perusal, once you open the abdomen, you look at the uterus, you look at the amount of neovascularization and the extension of this placenta, and you should have perseverance throughout the surgery. You should never be in hurry. Do not lose your nerves and keep your team in good mood and gradually proceed along with the help from the anesthetist and IV infusion and blood supply. And you should have a good partnership with your fellows like anesthesiologist, urologist, and neonatologist. So these 4 P's are very important if you plan to take up these cases and manage them. My references are, as I have shown. Thank you very much for patient hearing.
Thank you, Madam, for excellent presentation. Your 4P was the key message for the audience. That is very true. So, and you highlighted all the things, how to prevent these urinary tract injuries. It depends on the degree of pass and type of surgery. So it was very wonderful lecture, madam. And for expert comment, I request Dr. Mahesh Gupta, sir, to say.
See, the bladder dissection and bladder separation in the past cases is a 50% success. If you have successfully separated the bladder, then you can manage the case very easily. So now, most of the time, bladder injury occurs because of, as you said, hurriedness. So why there is hurriedness? That is because of the bleeding. So, as the Madam Alka showed, the put of Foley catheter, Foley tourniquet is the best thing just deliver the fetus, exteriorize the uterus, put a Foley tourniquet as low as possible, tie the Foley. So bleeding will stop. Then now you are not in hurry. Okay? Now you are not in panic. Now you are not in haste. Now you separate the bladder. Now the second tip is, our traditional teaching is to take a gauze and elevate the peritoneum and push the gauze. That is our traditional teaching. Or with the finger usually we are pushing the bladder. In past cases, never do this. Because in past cases, this myometrium is so weak. Most of the myometrium is eaten up by the developing placenta. So when you are pushing with the finger, that myometrium will not sustain that pressure and it will avulse. Once the bleeding will start from that area, that side, then you cannot stop that bleeding. So here the always sharp dissection with either ligature or biclamp or with bipolar shearer, with proper cautery and with calm and coolness. If you separate the bladder, your surgery is almost over. So these are two tips I want to share with the audience.
Thank you.
Yeah, please invite the next speaker.
Thank you very much, madam. And now I take the privilege of calling upon our next speaker, none other than the chairperson of the scientific committee of this conference, Madam Dr. Usha Didwania. Madam has been the past president of the Patna Menopause Society and is also the patron of the Patna Menopause Society. And she's an advisor, Fetal Medicine Committee of Patna Obs and Gynae Society. Other than speaking at various places, she has also been associated with various social organizations. So with this, I will request Madam to please carry on.
Respected chairpersons, my senior colleagues, and all stalwarts of Pphcon and my friends, junior colleague, very good morning to all of you. Since yesterday, you are listening all about PAS and placenta previa, and I have given this topic, facility preparedness, and that is the key of the management of this hemorrhage, obstetric hemorrhage. What do we understand about PAS? Nothing to say about this. Diagnosis is very important for the management, pre-op preparedness, and that is done mainly by ultrasonography in first and second trimester. And risk is very threatening, life taking, and the requirement, preparedness is a vast procedure and treatment. We have to be prepared for holistic management of cases, whether diagnosed or suspected or undiagnosed. So nothing to say about what is PAS, but clinical presentation when a patient comes antenatally asymptomatic or comes with hemorrhage, or during intrapartum, after normal delivery, or during cesarean section, we come across and think that case is of morbid adhesion. So golden rule of success of management largely depends upon risk assessment and preparation in place. Incidence is rising globally, you all know, and in our country, its confirmed data is not available, but it is around 19%. And you know, the incidence is rising with each successive cesarean section, previous uterine surgery, history of accreta, IVF, and advanced maternal age. And impact is maternal mortality, maternal morbidity, and neonatal morbidity, and hence a good homework is needed. And if you fail in preparedness, you prepare to fail. So to know the problem and to prepare to handle the problem, the identification of high-risk patient during antenatal period is very important with ultrasound, and diagnostic value is similar to transvaginal sonography if performed by expert. So problem occurs when any unexpected morbid adhesion of placenta case comes in front. And so we should be prepared about such situation when either we suspect it a case of APH or retained placenta, or blood vessel seen at uterine serosa at cesarean section. So if case is diagnosed, case placenta accreta, so we have to prepare ourselves for the time of delivery, mode of delivery, and place of delivery. If patient is asymptomatic, aim is to reach 36 weeks and deliver, or earlier if there is risk of threatened preterm birth. And if it is symptomatic, we should be prepared for those cases also. Clinical decision and availability of NICU support, aim for 34 weeks plus gestation, steroid to be considered. And mode of delivery, always cesarean section. The type of incision on a skin and or uterus will depend upon position of placenta and vessels, placenta, and the lie of the fetus. And place of delivery should be always a tertiary center where all the facilities are available. This is very important slide. Consent, informed consent should be taken in detail. Dr. M.C. Patel had mentioned all these important points yesterday. Elaborate discussion with patient and family to explain the condition, and documentation, very important. And they have to explain that it is a life-threatening condition, bleeding can be very severe, prolonged operative time, and risk of hysterectomy maybe is there. Patient may need hysterectomy, and with manual removal of placenta, secondary hemorrhage, chance of secondary hemorrhage is there, retained product sepsis, patient may be taken into OT again after some time. Option of leaving placenta and proceeding with cesarean hysterectomy is also discussed. If preserving uterus with placenta in situ, use of medical management should be discussed, and transferring the patient to a higher center should be discussed. Injury to surrounding structures, need of blood products, ICU admission, and mental health, anxiety, and depression. So for pre-operative preparedness, elective surgery preferably to be started in the morning, minimize starvation, oral glucose drink 2 hours before operation, no routine mechanical bowel preparation, identify comorbidity. This is very important to identify comorbidity in such cases, and antibiotic administration, 2 large bore IV cannula should be placed beforehand, and baseline all the lab tests should be done. Theater preparation, OT should be well equipped, prepared for massive transfusion, fluid warmer, rapid infusion device, and cell salvage devices. Blood and blood products should be ready, radiological endovascular intervention if possible, hysterectomy kit, internal iliac ligation kit, all emergency medicine, nursing staff well versed, anesthetic support for all arterial line and appropriate resuscitation. Pediatrician and urology involvement, neurosurgeon should be there. Refer to specialized tertiary care center, arrangement for patient transfer in equipped ambulance, or maybe, and before that, at the time of transfer to center, the referral form is filled, the referral diary should be there, and some expert nursing staff should accompany the patient. And the referring center should be well informed from beforehand. In unsuspected pass, at the time of elective cesarean, where both mother baby are stable, immediately apparent that placenta percreta is present. On opening the abdomen, the cesarean section should be delayed until expert colleague is there and resources have been assembled, adequate blood products are available. This may involve closure of maternal abdomen and urgent transfer to a specialist unit for delivery. When a placenta is left in situ, local arrangement need to be made to ensure regular review, ultrasound examination and access to emergency care should the women experience complication such as bleeding or infection. Hysterectomy may be necessary. Post-delivery PPH and retained placenta, post-spontaneous delivery or cesarean section. If bleeding ongoing, cesarean hysterectomy, preferably with placenta in situ. Then pass in low resources scenario. This is the problem with us. In our part, there is, in villages, there is, facilities are very poor. So from beforehand, education of the caregiver about PAS and patient of the importance of antenatal care. They should have a regular antenatal care. Then importance of 20-week scan should be there. And TVS to rule out placenta accreta if placenta is low-lying in previous ultrasound. Early referral to tertiary center if possible. Arrangement for blood and in the absence of radiological support, cesarean hysterectomy with placenta left in situ if not bleeding actively after clamping the cord. In unexpected condition, elective cesarean, do not proceed with uterine incision if diagnosed when entered abdomen and have a colleague to join in, and if not possible, close abdomen and reorganize with preparation, communicate with patient and family, close abdomen and transfer to tertiary unit. Then prepare for cesarean hysterectomy preparation can be done in emergency situation. Telemedicine can help. Post-operative important, as just now this topic has been dealt. Then for checklist, diagnosis, time, date, multidisciplinary team should be available, blood product, IV fluid, hysterectomy, ambulance.
Can we have some silence, please?
And this is the reference. Thank you for the patient hearing.
Thank you, madam, for your lecture. But here the preparedness is particularly patient. The tagging of the high-risk these cases should be done in the antenatal period. And all patients were given the FCM injection because the anemia is a main killer in such kind of the cases. So all patients' hemoglobin should be adequate.
Yeah, for preparedness
yes.
from before, and pathologist has to be consulted before, and her general condition should be very well managed since the beginning of the pregnancy. In all cases we have to do that, but in such cases we take extra care that her hemoglobin and other...
Hemoglobin should be maintained, vitamin B supplementation should be done, and vitamin D3 also should be done.
Everything is good.
Yeah, so less number of the blood transfusion will be needed during surgery.
Yeah.
Thank you, madam. Thank you.
All right, with this, let's give a round of applause to our chairperson also and all three speakers. Well, it's time for oration. And I request Dr. Neebha to please come on desk and invite our chairperson and the esteemed speaker. Please come down for a picture there at the booth. Thank you.
Good morning, everyone. Once again, a very warm welcome to one and all in this Foxy PPH conclave at Patna. The most awaited moment of any conference is conference oration. So here we are. With great applause, we wish to say that orator of this prestigious oration is none other than our own Foxy President, Dr. Jaideep Tang sir. A very dynamic, vibrant, disciplined president, full of academics and with great vision, taking Foxy to a newer horizon. For this prestigious oration, may I invite our esteemed senior members to chair the session. Sir, Madam को ले आइएगा, Madam को बुला के ले आइएगा. First, may I invite Padma Shri Dr. Professor Shanti Roy Madam on the dais to chair this prestigious session. Madam is our loved teacher, guide and mentor, past President POGS, recipient of Lifetime Achievement Award of many societies. Madam, please come on the dais, Madam. To her credit, there are many prestigious awards. Madam has written so many books and she is boon to our society, consultant at Shivam Hospital, Patna. Now, may I invite esteemed member of our society, Dr. Manju Gita Mishra, Madam. Madam needs no introduction. Sir, you want to? Pillar of our society, always guiding us to take our society to a greater height. Madam is past president of POGS and recipient of many Lifetime Achievement Award. To her credit, BC Roy National Award. Welcome, Madam. Now, may I invite Dr. Usha Didwania, Madam, the scientific chair of this Phoxy PPH conclave, and she has done a hard work to get this scientific decorated. She is also patron of Patna Menopause Society. Now, may I invite the lady behind the show of this PPH conclave, Dr. Meena Samant, organizing chairperson, president of our society, and head of the department of Kurji Holy Family Hospital, to over the esteemed chairpersons to start this prestigious oration.
Thank you very much. So I invite, as said by just now, that this is one of the most important session of this PPH conclave. That is conference oration, and it is going Dr. Jaideep Tank, who is the president of Phoxy, is going to deliver this oration. So please, Dr. Jaideep Tank, come and give the oration. And the formal introduction will be given by Professor Shanti Roy.
Thank you very much, President and Secretary, for inviting us for this very important oration, the conference oration, to be given by none other than our own President, Dr. Jaideep Tang. He is chairperson of YAGA. Sorry. Hello. He was immediate past Deputy Secretary, Asia Oceania Federation of Obstetrics and Gynecology. That means AOFOG. Immediate past Chair International Federation of Obstetrics and Gynecology, that means FIGO, Committee for Safe Abortion. He past Chair Publication and Newsletter Committee, AOFOG.